India is a big country with 1.3 billion people living in 36 states and union territories, spread over in more than 700 districts in the country, in more than 650,000 villages, in different social, economic, and geophysical contexts. Country is facing dramatic and widespread demographic shifts, and this will nevertheless pose challenges of aging population in our country. LASI report is particularly relevant in this context. Over the years, I must say, Government of India has taken several initiatives, several health and social policy measures to enhance the well-being of the elderly persons. National Program for Healthcare for Elderly aims to provide comprehensive healthcare to the elderly through primary, secondary, or tertiary care delivery systems. Ayushman Bharat is an initiative in this direction for continuum of care. Various national programs, particularly NPHCE, program for prevention and control of deafness, oral health, tobacco control program, palliative care programs, and so on, have components of elderly care as well. And comprehensive geriatric assessment is a multidimensional and multidisciplinary process to identify medical, social, and functional needs of the aging population, and the development of an integrated and coordinated care plan to meet those needs. The integrated care programs are being implemented in varied settings, from primary healthcare to tertiary healthcare settings in our country. And today's theme is quite relevant in that perspective, because the theme of today's discussion is integration of comprehensive geriatric assessment and delivery of care through the components of various national programs in the country. In this discussion, we have outstanding speakers who are basically subject experts in their own field. We have with us Dr. Arvind Mathur from AIIMS Jodhpur, Dr. Praveen Bashish from AIIMS Delhi Community Ophthalmology Department, Professor Beena Jain, AIIMS Delhi, Dr. Agarwal, who was MS and ex-additional DG in the ministry, Dr. Sushma Bhatnagar, Dr. Shiv Kumar, Dr. A.B. Day, and we have with us eminent personalities who will be listening to this program today in various parts of the country. And I must welcome you, each and every one of you, in today's program. And my special thanks to Dr. Govt, who has taken the initiative on behalf of National Program on the occasion of release of the National Report of LASI and organizing this event, which will bring the expertise for integration of national health programs in this initiative. So I invite Dr. Sunila Gak, who is with me as moderator also, to I'll basically hand over to ma'am to organize, to coordinate, to moderate this program right now. Welcome, Madam Dr. Sunila Gupta. Sunila Garg, please.
We can't hear you at all, Dr. Gauri. We cannot hear you at all. Voice is totally muffled. There is lot of disturbance. Maybe you can close the host one and then you can start from the another one. It could be like that. You can go to the host side and then, because there are two which are working for you. Okay. Yeah, hello. Dr. Anupam, I'm in a meeting. I'll call you back. Hello, can you hear me now? Dr. Gauri, we can't hear you at all. We can't hear you at all, and there's a lot of disturbance.
Hello. Hello. Am I audible now? Yes. Hello. Yes, Dr. Arun Agarwal is giving me a thumbs up sign. Thank you, sir. Thank you so much. Okay. Put in the PPT. Okay. I welcome all of you. Dr. PK Sen has already done my job of welcoming. I thank you very much, sir. And please do let me know, sir, if I am not audible. I don't know what is happening at my computer today. So I'm thankful to all the experts who are going to be deliberating today. My job is just to give you the brief overview of just the 4 objectives of this particular workshop, primarily because the LASI findings have got 3 major domains, that is health, social, as well as economic domains. Today, we shall be addressing only one domain, that is health domain. And in that, we are also going to be addressing only 6 different specific elderly care domains. That is eye care, ear care, mental health, palliative care, orodental, cardiovascular, and other involvements. In this, along with this, we are also going to be talking about how we can put it into perspective of delivering comprehensive care assessment as well as delivery mechanisms within the existing national health programs and evolving mechanisms for future delivery of services also. So without further ado, PPT? It's coming as share content. Okay, so some technical glitches. The first objective of the workshop is definitely to disseminate the findings of the health domain relevant to elder care, because LASI being a very huge study, we have Dr. Shekhar from IFPS who will be giving us a brief overview of the health domain findings pertaining to these 6 domains that we are going to be discussing today. A second objective is to identify specific healthcare needs of the elderly, which shall be deliberated upon by the experts of the field. To understand the services available in the national health programs for the elderly people, we will have the program officers of each of these programs deliberating about what is it there that is there in their program presently. And our basic goal is to develop mechanisms or targeted interventions within these national health programs to deliver comprehensive geriatric care assessment and services. Without further much ado, I hand over the whole session to the able moderators, Dr. P.K. Sen and Dr. Sunila Garg, to conduct the first panel. Through the web link, and he shall be recording the whole session of panel 1. I hand over the mic to Dr. Sunila Garg as well as Dr. P.K. Sen, sir.
We have already given an introduction to these discussions for today and the relevance of release of LASI, and at the same time how comprehensive geriatric assessment can be incorporated into the assessment, and also elderly care can be integrated in the various national programs. And I'll now request Ma'am Dr. Sunila Garg to invite the speakers and moderate the session.
My profuse thanks to Dr. Sen and Dr. Gauri. And it was really an exciting day today when we had the release of LASI report, and never before that we have got this longitudinal report. And I got an information from Dr. Arun Agarwal also that he is to leave very shortly. So if everyone permits, we can listen to him before we go to Professor Shekhar. That's sir, if you can highlight what are the healthcare needs of elderly with regard to rhinolaryngology problems and what is there inbuilt within the program. That will be very good. And I'm sure I have the permission of everyone over here. And Dr. Shekhar and Dr. Mathur, I hope you will be permitting me for the same. Thank you. Dr. Arun Agarwal, please. You can unmute yourself, sir. You have to unmute yourself. Unmute. Is he muted from our end at the ministry? So you can unmute. Yeah.
No, ma'am,
Actually,
he's been made a presenter. He's been made a presenter. Presenters can unmute themselves.
You can unmute yourself, sir, now. Yeah, thank you. Okay.
Thank you. Thank you very much, Dr. Sen, Dr. Gauri, Dr. Sunila, all my colleagues, experts sitting in front of us. And thank you for allowing me to prepone my talk, which I promise will be comprehensive and in short time. When we talk about otorhinolaryngology and elderly, perhaps it forms a very important component. But if it is important, but at the same time, perhaps if I look into the entire history of geriatric care, we could not get appropriate place as regards the geriatric care as well as the geriatric medicine is concerned. We know that otorhinolaryngology is, as Gauri also said, we will be talking about ear care, deafness. I fully agree, and I'll be briefing something more about deafness. But there are other related symptoms, problems which an elderly person faces in relation to ear, in relation to deafness, and I will also take little time. So let me talk about the hearing loss first. The hearing loss, which we call presbycusis, which is called aging deafness, elderly deafness, is because of a normal layman's language, a normal wear and tear of our hearing system in terms of hair cells from the inner ear, and we are bound to hear a little bit less as compared to a young person after a certain age. And this age is supposed to be, as per literature, 60, 65. But in Indian scenario, we find that this age is coming early. We are getting early aging deafness because of many factors. Speculations are there, theories are there, and those theories, mostly it is related to number one, the level of noise being exposed. We all in together in the society, we are very fond of noise, and this noisy atmosphere has become part of our life. That is why perhaps we are getting early presbycusis, besides the status of generalized non-communicable disease like hypertension, blood pressure, etc., etc. So we are getting early presbycusis, aging deafness. Definitely there are reports from different surveys which shows that, well, we have around 30%. If we look into 60 plus age group, there are reports of 30% people. If you look into 70 plus, then it is 40%. And if I look into 80-year plus, then perhaps more than 50% people are suffering with disabling hearing loss. Disabling hearing loss indicates one thing, that perhaps I'm not able to look after my need. And what is going to be the outcome of that, I'm going to explain to you. So this hearing loss is one which is there in each and every family. You agree that the senior citizens of our elderly are suffering, but unfortunately, this hearing loss is least taken care of by the person who is suffering himself or herself. They never try to give importance to that. And if somebody points out, the normal saying is "sab chalta hai," और अभी चलता है, तो फिर वो they less and less care is taken of. The fact is that when we start hearing less and there is a hearing disconnect, I always try to see if Dr. Rajiv Garg is there in this seminar also, then Rajiv, my colleague from ophthalmic, will agree that there are stimulants which body requires, whether it is sensory, whether it is hearing connect or the vision connect. And the moment we have hearing disconnect, then we tend to become aloof. In different scenario, in family scenario, the people who are suffering with hearing loss, they tend to isolate. And that is why there is change in their attitude, irritation, etc. And aloofness brings many psychological changes. But what is more important nowadays, my expert from geriatric medicine are there, that now we are trying to correlate very strongly, even WHO, Geneva agrees to that hearing loss, Dr. Gauri, this is very important for us to understand, that hearing loss disconnect is proving to be a predisposing factor for early dementia. So I'd like to explain to you that what is the hypothesis? The hypothesis poses that the hearing loss causes brain reorganization and or social deprivation. As I said, that when we are not able to, it leads to social deprivation, resulting in cognitive decline. And when there is there is a cognitive decline, then dementia may be impacted by the social isolation. That could be a result of hearing loss. People with hearing loss may not be confident in responding or reacting appropriately and may choose to disengage themselves from the conversation. And as a person with hearing impairment withdraws from social engagement. There is also a reduction in the amount of cognitive function necessary to assess and interact with his or her environment. And ultimately, this may impact executive function ability. So that is what I wanted to emphasize, that hearing loss is not only leading to hearing loss, but it is directly, indirectly connected with cognitive domain, and it is perhaps leading to many more neurological conditions which are more challenging in elderly age, which we have to be very, very careful. A lot of activity research is going on, and that is why it is important for us to look after the hearing loss in elderly, which is often ignored. Of course, the solution is repeated hearing test and rehabilitation in terms of the affordable but best quality hearing aid devices, etc. Besides the hearing loss, in the ear, one of the very disabling conditions which often our senior citizens face is tinnitus, ringing sensation. It is linked with hearing loss. It is linked with many more things. And exactly as ENT surgeon, let me confess that the exact mechanism of ringing sensation, tinnitus, is not very well understood. But the fact is, it is there. And believe me, those who are suffering with tinnitus, they really suffer. They really suffer. They know what is the pinch of tinnitus. So this is also one thing which has to be taken care of. And the third ear-related problem, which is very commonly seen, is collection of wax into external auditory canal, which itself is a predisposing factor of hearing loss, as well as the sense of irritation, dryness, as well as if the person is using hearing aid, perhaps he does not know that he is having collection of wax. So collection of wax has to be taken care of. And above all that, in relation to ear, let us not forget that there is a increase incidence of vertigo. The moment we have geriatric age group, we all agree that because of many factors, the most common factor is benign paroxysmal vertigo, where there is positional nystagmus, and we tend to have, of course, there are many reasons, and cervical spine is one of the theories when there is spondylosis, but you will agree that elderly people suffer with vertigo a lot, and sometimes this vertigo may become cause for many more complicated conditions. Maybe that you lose your balance. So this instability, which being addressed at many platforms, should be taken care of. Besides this ear problem, what I mentioned to you, it is my duty to share with you that beside hearing loss, let us not forget that if I try to take, Dr. Gauri, the total communication of elderly person to the society. And for communication, it is the hearing power as well as the speech. And when elderly person has something called dysphonia, because of the loss of muscle strength, the vocal cords also lose their strength. And that leads to dysphonia. And if you recollect that when we meet, we are two vocal cords meet, and if there is a gap, then this gap leads to a dysphonic voice, which is perhaps not very well understood by the person who is hearing the voice. So that also requires appropriate attention, which is also a very important part of communication. The third important part in relating to ENT is dysphagia. Many of times you must have heard that I'm not able to swallow. Of course, I'm not talking about the pathological conditions, but I'm talking of the normal physiological dysphagia in sense of when there is loss of strength of muscle. It also leads to dysphagia, and there are it's one of the very common problem in some of the studies. At least more than 10% people of elderly age group were found suffering with dysphagia, and even more than that. Besides this problem of communication in terms, there are problems of dryness. Dryness, of course, my colleague from dental will be talking, the entire dryness of the oral cavity or the larynx and pharynx, which itself give a sense of cancer phobia, etc. But it also leads, if there is a dryness of the nasal cavity, it sometimes leads to epistaxis, the nasal bleeding from in elderly age group, and this is also correlated to hypertension. So these are some of the conditions I thought I'll share with you.
Yeah, sir, I wanted to, thank you so much, sir, for highlighting the important things and National Program for Prevention and Control of Deafness. I had the honor of being associated with Dr. Agrawal to formulate the program. And then secondly, what is important is that the program is very comprehensive from pediatric to geriatrics. It talks of everything about elderly care. When we are talking of, when sir mentioned about hearing loss, he mentioned about social isolation, he mentioned about the wax part, and he mentioned about the ringing sensation, and so many other aspects. So what I would like to bring to this platform is that the program is very structured right from the primary level till the tertiary level, in terms of not only the identification of hearing loss in the elderly, but also we are talking of the rehabilitation part. Sir, if I can add this to the whole thing with regard to NPHCE, because the time is short. But another thing which is very important, Dr. Gauri and Dr. Sen, which I would like to bring to your attention, sir has forgotten, or maybe he's very busy, 3rd March is World Hearing Day. We will put this as an important stakeholder meeting as part of, because on 3rd March we are going to have release of World Hearing Report, and which is going to be released, just before World Health Assembly, where the total component of hearing will be incorporated, and we will put this as a major component, this meeting as a major component before the World Hearing Report, and we'll be sending the whole information to the headquarters, Geneva. So thank you so much, sir. And if you want to add any point,
No, Sunila, I'll just take 1 minute in just adding.
Only 1
Let us
minute, sir.
ignore the hearing loss. I'm talking of total communication on part of elderly person. It includes the speech, the voice, and hearing part. Let's not forget, and this is why I'm emphasizing again and again, because it has got direct connect with the cognitive disorders of the brain, and which is often ignored. That is why I must emphasize that our geriatric program should give appropriate importance to this particular. Thank you. Thank you, Dr. Gauri, Sunila, Dr.
Thank you
Sen,
so much,
and all my
sir.
colleagues.
Dr. Sen, will you like to add anything before we go to the next? You have to unmute yourself, sir. You have to unmute.
It's nice to hear Dr. Agarwal, and he has nicely mentioned about the hearing loss disconnect, in particular with cognitive decline and the dementia leading to social isolation. This is very important. And regarding this 3rd May program, DGHS has already participated in the preliminary meeting.
Yes.
So it will be good to add this particular program, this particular initiative today to that during the day of World Hearing Day.
Thank you. Thank you so much. So, can we go to
Sunila,
the
with your
next?
permission, thank you very much. And can I be permitted to leave?
Thank you, sir. Thank you. Thank you.
Thank you, Dr. Sen. And bye.
So, Dr. Sen, Dr. Gauri, we will move to the next speaker, that is Professor T.V. Shekhar. He is going to highlight on the major findings of LASI in the health domain. So, can we have the pleasure of hearing Dr. T.V. Shekhar, please? Are you able to share your screen, Dr. Shekhar?
Yeah, I'm able to. Okay. Good afternoon to all of you, and I'm very happy to present before you some of the important dimensions and findings of longitudinal aging study in India, LASI. Since a large number of participants who have joined today are not familiar with the LASI, its methods, its coverage and scope, Dr. Gauri Sengupta requested me to give a brief introduction to the LASI, its methods, coverage, and scope, and then give some of the important findings related to health domain. So, as you are aware, the aging scenario in India is changing very fast. Since we are very late, I don't want to elaborate much on this. The demographic and epidemiological transition in India has shifted a major share of countries' burden of disease from children to older population. So, given this context of the tremendous increase in the aging population in the next 20 to 30 years, approximately to around 300 million, the need for a longitudinal aging study was felt. In India, we don't have any nationally representative data set for the older persons and particularly aged. Most of our surveys, like National Family Health Survey, focus on the women in the reproductive ages. And there is also a substantial premature burden of non-communicable diseases starting from 45 onwards. And we also need to have internationally comparable and globally acceptable data. So LASI is designed to meet all these objectives. LASI is India's first nationwide longitudinal study, and in terms of its coverage sample size, it is the largest longitudinal aging study in the world. Now, the LASI first two waves were designed and prepared from 2016 to 2022. LASI is supported by Ministry of Health and Family Welfare under the National Program for Healthcare of Elderly, Government of India, the National Institute of Aging, NIH, USA, and United Nations Population Fund, India. International Institute for Population Sciences is the nodal organization who is implementing the LASI and taking the major responsibility of this. We are also joined by our international collaborating institutions, Harvard T.H. Chan School of Public Health, led by Professor David Bloom, and University of Southern California, led by Professor Jingu Lee. I would also like to mention here the former PI of India team, Professor P. Arogyasamy. At the national collaborating institutions, we are collaborating with the regional geriatric centers of the Ministry of Health and Family Welfare, and the National AIDS Research Institute, ICMR NARI, is doing the storing and testing of dried blood spot samples. And Chest Research Foundation, now known as Pure Foundation, is helping us in conducting the spirometry test and analysis. So in 2016, the launch of the LASI was done by the ministry under the National Program for the Healthcare for Elderly. Now, with LASI, India has joined the elite club of health and retirement studies around the world. Nearly 40 countries are conducting health and retirement studies. So LASI protocols, questionnaires, everything designed for cross-country and cross-cultural comparisons with other health and retirement studies. Now, what are the important goals of LASI? It is to collect the internationally comparable research design tools and adopt cutting-edge scientific methods to provide the foundation of credible and acceptable data for national level policy making and also scientific research. LASI will provide much needed scientific data for strengthening the programs of the National Program for Healthcare of Elderly. Just before this, when Honorable Minister was mentioning about the importance of LASI in the context of NPHCE, LASI will enable strengthening the existing and social security pension policies of Government of India, and will also help us to have a comprehensive national health policy framework for older persons and expanding the healthcare and social security programs to cover all older adults and elderly persons in the country. Now, LASI covers 4 important major domains. One is the health, disease burden and risk factors, both reported as well as measured, because we have a large number of biomarkers included in the LASI. We are also focusing a lot on healthcare financing, healthcare expenditure issues. At the family level and social level, we cover a lot of issues, including the social security programs for the elderly. And another important dimension is the economic part, which includes income, wealth, expenditure, consumption of the selected individuals and households. Now, coming to the health part, this will provide giving us a robust estimates for the prevalence of communicable and non-communicable diseases for the adults population aged 45 and above, and more focusing on the 60 plus population. And to compare the self-reported and measured health conditions and provide an overall assessment for the total burden of diseases with a particular focus on non-communicable diseases and the associated risk factors among adults and older population. And also to study the risk factors and social determinants of communicable and non-communicable diseases, including the economic and environmental factors, And finally, to understand the demography of aging transition, epidemiological transition, causes of death, life expectancy at older ages. So during in the domain of healthcare and financing, we have the information at the national level as well as the state level on the coverage of healthcare utilization, disease pattern, and also the household health expenditure, the medical costs on treatment and sources of healthcare financing, to study the health insurance schemes and the availability and access to that, and also the quality of care. Coming to the social and family dimension, we have the information about the living arrangement, multi-generational family structure, the networks of family and friends, social support, financial support, participation in social activities, participation in organizations, and life satisfaction, everything. And also the financial and economic support received and provided by elderly. LASI survey shows that there was a general impression that elderly are a liability and burden for the family, but LASI survey indicate that good percentage of elderly are economically contributing to their family in a big way. And it also gives information about caretaking and caregiving at the household level, and information on the elder abuse, ill treatment, isolation, and also how the elderly perceive their satisfaction in their life and different aspects of life. In the economic dimension, we have a large number of questions on economic well-being, which includes the income, expenditure, assets, debts, employment, retirement, and pension, and perceived economic security, vulnerability, and expectation. And to study the economically active older population, the work participation among the elderly, and their job characteristics, the housing conditions of elderly population, and poverty and food security among them. So the LASI, as mentioned in the morning, is designed along with the comparable with other similar aging studies across the world, but a lot of innovations. It covers all dimensions of health, economics, sociology of aging transition. It has very comprehensive biomarkers for direct health examination. And we are using the computer-assisted personal interview, CAPI, to collect the data to minimize errors and other things. And all IT-based technologies like GPS and barcode technologies also utilized. Now, basically, LASI have three instruments. One is household survey schedule, which covers the household roster, housing, environment, consumption, asset, debts, household income, and health insurance at the household level. Then we have another major section of the individual interviews, individual questionnaire, which covers all aspects of demographic, family, health, work and employment, retirement, experimental models. Interestingly, LASI have a third schedule, which most of the other surveys do not have, that is the community survey. Collecting the information from the communities where the survey was carried out. So that will enable us to compare the community characteristics and community facilities and infrastructure with healthcare utilization and other performance of the individual living in those areas. So coming specifically to health, I just want to highlight you in the health section. We are collecting information about all these aspects on the diagnosed chronic diseases and epidemic disease, endemic diseases. Mental health, we have a lot of information. Functional health, healthcare utilization and health promotion, women's health, family medical history, health behavior including smoking, consumption of alcohol, physical activity, spirituality, and food security. So it's one of the very comprehensive data set is emerged for India as a whole and the states in particular. And as I said earlier, LASI's one important dimension is the direct health examination through biomarkers. We have the functional health measurements like blood pressure and pulse rate, lung function test, spirometry, and vision test. We have the anthropometric measurements of all the individuals surveyed, the height, weight, waist circumference, and hip circumferences. And the dried blood spots assays were tested at the ICMR Nari lab in Pune for the C-reactive protein, hemoglobin, HbA1c, and hemoglobin. And we also have performed base test on grip strength. It is one of the good markers of aging and health, timed walk, and balance test. So LASI gives a very comprehensive set of biomarkers and the data. Now, overall, LASI is providing us a national estimates as well as state estimates for all the states and union territories. Somehow in the state of Sikkim, we could not complete the survey. Otherwise, we have the information for all the states and union territories. It covers all the persons 45 and above from the selected households. So and the survey is planned in such a way that every 2.5 years, we will be going back to the same households and same individual to find out the social, economic, and health changes of the surveyed people. So it is a longitudinal design, and the first wave of this survey was carried out in 2017 and 18. Now, broadly, the implementation part, we have the mapping and listing of the household of the selected areas, both in rural and urban areas. From there, the households were selected on a scientific, systematic manner. A survey team consists of 6 members will visit the selected locations and identify that 30 selected households and interview the households and individuals 45 and above from that households, including the biomarker collections and including the DBS. And also all this is done with a very meticulously planned supervision, network, and training. And the data is transferred immediately from the field to the server in IIPS, and it is also analyzed. And the DBS samples were couriered to the ICMR Nari lab in Pune. And it is, so all the latest technologies were used to provide the most accurate and efficient data at the in a most scientific manner. Now, the survey also includes training and supervision to ensure the data quality. So we have a 3-tier supervision and monitoring of survey implementation. One at the level of the IIPS, we have a large team of health, IT, and research and project officers working. And during the survey, IIPS is also deputing some of our staff full-time in the field to see that the surveys are conducted in a proper manner. And we also have the selected field agencies who are experienced in conducting similar type of surveys. So they were trained under the guidance of IIPS, and they in turn trained the investigators and the field survey team. And it's all supervised by, and particularly the biomarker component is also supervised by regional geriatric centers of ministry located at various medical colleges in the country. Now, overall, we covered 42,949 eligible households were interviewed. From there, 72,250 individuals were interviewed. 72,250 individuals were interviewed, and which includes 31,000 elderly persons and nearly 6,700 old persons around 75 years and above. So the urban and rural response rate is also given here. Now, it is a very tough job to conduct a survey like this, and it takes a lot of time. So a survey team consists of 6 members with a dedicated vehicle, including a health investigator with a paramedical background, went into the field and spent 5 full days there to interview only 30 households. So the CAPI, the program is arranged in such a way that the interview can be scheduled anytime in the 5 days, or part by part it can be conducted also. So the household interviews, the individual interviews, and biomarkers. And we are also collecting the community questionnaire from the village head and the local officials related to the characteristics of that area. So the LASI national report, which was released today afternoon by the Honorable Health Minister, Dr. Harshvardhan ji, which covers very detailed analysis and explanation for all the issues which I have mentioned here, which we have collected, and it covers 16 chapters on all dimensions of the health, economic, and social aspects. And the report will be shortly available on the website, and I'm sure all of you will be eagerly waiting to read that report. Now, coming specifically to a few of the important findings related to the health status of the elderly, I now request my colleague, Dr. Sarang Padgaonkar, MD, who is also a faculty at IIPS, to present some of the few important findings related to the health on this occasion. Dr. Sark.
So, Dr. Sekhar, sorry to interfere. This is a very, very important presentation which forms the basis of the total session. So, how much are the slides which will be telling us about the observations so that we can time the session accordingly?
We will take 5 minutes.
Thank you, Dr. Shekhar. Thank you. Because it has been very, very beautiful presentation, and I'll be summing up your presentation also. So, thank you so much. Thank you.
Thank you, ma'am. Dr. Sarang.
Thank you, sir. This first, I think I am audible enough. This first slide summarizes the clinical findings of about various chronic health conditions. So it speaks about the age-wise prevalence of various self-reported diagnosed conditions in LASI. And from here we can see that the prevalences of cardiovascular diseases, hypertension, diabetes, they are steadily increasing over the ages across almost all the age group, and similarly, even some chronic conditions like bone and joint diseases or neurological or psychiatric conditions or chronic diseases, they are also showing a steady increase over the as the person ages. The next slide is about the presence of morbidity, and we can see that at age below less than 50, about 73% people are free from any morbidity. And the percentage falls down to about 55% when the percentage is 60. And the people, the single morbidity prevalence increases steadily, and similarly the prevalence of multi-morbidity, which is presence of more than one comorbidity in a person, and that reaches as much as about 25% in the group of 70 and above. So next slide is the self-reported prevalence of various diagnosed health conditions in the people age 60 and above. And so the self-reported prevalence of diabetes in India is around 14%, and the results of HbA1c will be coming out from now this condition information. Then the prevalence of the prevalence of cardiovascular diseases increases with age from 22% in the age group of 14 to 59, and it reaches up to 37% in the people age group 75 and above. And from here we can also see that the hypertension prevalence of self-reported condition, it is about 32%, and bone and joint diseases are about 19%. So the self-reported prevalence of cardiovascular diseases, if we look by age group and the male, female, and upper distribution, so we can see the steady increase in the prevalence. The major difference among or the gap in female may be attributing to their longevity, and more prevalence in the urban population than among rural. So the prevalence, we also as a part of biomarker measured the blood pressure among the individuals using portable sphygmomanometer, and we took 3 readings of the blood pressure, and the average of the last 2 readings was taken to find out the estimates of prevalence of hypertension. And we can see that this measured prevalence is something that these people, they were found out to be having high blood pressure at the time of field visit, regardless of their diagnosed status. And the gap between diagnosed and self-reported level is around 4%. So means 4% prevalence was higher when we were looking at the people who were for measured hypertension. And again, the distribution of states is particularly the prevalence is higher among the southern and the, what we say, demographically more advanced states in India. So this difference, when we analyze with the available data of taking the treatment and having been diagnosed at some point of time by some qualified physician about the presence of hypertension, then we can see that about 42% they are adequately treated for hypertension. So this portion means that these people, they are having hypertension, they have been diagnosed with hypertension, and they are taking treatment, and on measurement their blood pressure was within normal range. Whereas this is the group of people who regard without taking any medicine by some other means, but their blood pressure was found out to be within normal range. This blue portion is something that these people have never been treated for hypertension, and this about 1/3 of the population. So they have been diagnosed with hypertension. They are taking certain type of treatment for hypertension, but their blood pressure readings are yet not adequately controlled, or they are still having blood pressure in the higher ranges. So as a part of biomarker, we also add this grip strength measurement, and we can see a steady decline in the grip strength measurement as the person ages. Now we can analyze now this data with other HRS studies, and we can find out how the decline in Indian population is in comparison, or how it goes along with some other studies across the world. So another important thing is the nutritional status among the adults, and we have used the body mass index as well as the stiff ratio for assessing the obesity and abdominal obesity. And we have found that about a quarter of the elderly age 60 and above, they are underweight, and about a fifth or 22% they are overweight or obese. So we can say that still we are having a double burden of malnutrition, where we are seeing undernutrition at one place and overnutrition at another place, and overnutrition, it is kind of on the rise that across the age. And the prevalence of undernutrition and overnutrition in the states wise, so we can see a picture here. Now here the age group is 45 and above. The underweight is more in states like Chhattisgarh, Odisha, Uttar Pradesh, Jharkhand, Tripura, and it is lower in the southern states like Kerala, Punjab, Goa, Jammu and Kashmir, Lakshadweep, Tamil Nadu, Karnataka, Maharashtra, and Telangana. Whereas overweight and obesity, we can see the same states who were having lower prevalence of underweight are now having higher prevalence of overweight or obesity, like Chandigarh, Punjab, Andhra Pradesh, Himachal, Kerala, Goa. And the states which we are talking here, they can be found here, like Bihar, Odisha, Jharkhand, Assam, Chhattisgarh, and Meghalaya. So when we are talking about impairments, we have found that about 11% of elderly above 60 and above, they have reported of having at least one form of impairment, which can be either locomotor, mental, visual, or hearing impairment. And that prevalence is around 6% among the older adults in the age group of 45 to 59. And among the elderly age 60 and above, the locomotor is the most prevalent impairment, which is followed by visual impairment, then mental, and the hearing impairments. We have also collected information about the ADL and IADL limitations, that is activities of daily living and instrumental activities of daily living. And about 14% of the elderly, they are reported having 2 or more ADL limitations, whereas 37% of the elderly, they have reported of having 2 or more IADL limitations. So this is 2 or more IADL, and this is only one IADL. The percentage of older adults using aids or supportive devices by age, place of residence, and sex. So the most frequently used aid was spectacle, which is followed by some aids for the physical disability, and then dentures and hearing aids. So in the rural urban also, again, the use of these aids is more among urban area, and the most common being the spectacles. So these are the few snapshots where we are conducting interviews, the blood pressure measurement in a sitting position. Then this is the blood correction for DBS preparation. This is the interviewer performing this spirometry, grip strength, and other interviews. So with this, I thank you all. Thank you very much.
Thank you, Dr. Sekhar, for a very, very lucid presentation. I think one of the important things which I would like to bring out is it is truly a multi-dimensional international standardized study with a robust study design. And the important stakeholders are not only Ministry of Health and Family Welfare, but from the International Schools of Public Health, University of Southern California, and all that. What is more important today is that, which I am able to share with you with an little experience of about 4 decades in the community settings. And now I'm also having an NIHR project where we have a very robust study design. And I could see that this design of the study was equally as robust, both when we talked of rural and urban areas. You started with talking about, the demographics, the need for the study, and, the important dimension of your study was usage of the computer assisted interviews so that you will have minimum errors. And you had 3-phase interviews: household interviews at individual level, community surveys, and you got the health information also. And also you went ahead with the direct health examination, which will supplement the findings. And you also use biomarkers. Another important thing was that you also gave a brief snapshot. Everybody has got the executive summary and the report. They can go through that. It is a very interesting report, let me tell you. And you talked about the comparison between the self morbidity and the actual morbidities also. And you also went on to looking at the main grip strength and all of those things, and how you see NFHS survey has also shown, particularly in context of children, the increased prevalence of malnutrition. But our study in elderly, this study will go a long way in forming a strong base when we go ahead after 3 years to have a strong comparison with line of undernutrition, non-communicable diseases like hearing impairment, or when we look at the other parts like spirometry and all that. So I feel that it is very important from the perspective of not only the public health angle, but from overall specialist angle also, we can comprehend this, and we can have individual rather not this meeting. I think Dr. Gauri and Dr. Sen, this will form a beginning of a major stakeholder meeting in different groups. Thank you so much. Thank you, Dr. Shekhar. And now we go on to the next presentation, which is there by Dr. Arvind Mathur, and he will be talking about the lessons which we have learned from LASI. This is the Comprehensive Geriatric Assessment and Care Requirement. Dr. Mathur, please. And I will appreciate that, if we cut 1 minute each so that, everybody gets time, to speak. So Dr. Mathur, though it's a pleasure to listen to you always.
Thank you very much, our distinguished moderators and our colleagues. Dr. Shekhar and his colleague has made my life easy by giving an overview of the health findings which we have got from LASI. I'll just like to discuss some implications on the way we take care of the older people. And as has been seen, that this is due to a unique status of our country, where we have got marked geographical cultural diversity with demographic transition and epidemiological transition with all the population which is occurring. That has caused the need for having a comprehensive, internationally comparable national survey, which has already been done. And I think from the domains have already been defined, that we had all the domains covered which are needed for the health care. The important thing which has come out of the study is that the health issues, they are affected by, which we have seen in the presentation also earlier, that from the regional variation, there is a marked regional variation. When we look at the national average, there are states with wide variation. That is one important thing. All the health conditions, they have been affected by age, which has been shown even in the cardiovascular diseases or other conditions also. The residence also makes the difference in the health, and the urban and rural divide is seen in the report itself. Gender differences are highlighted with this study, and the impact of economical and educational status has also been highlighted by the study. So this particular study is one of its kind, which gives scientific basis to all these factors which are affecting the health. And probably they will be forming a basis for our interventions also. As has been seen that the chronic health conditions are quite common over there. The important thing is that there is a self-rated health is quite low in elderly as compared to the younger adults. And also the treatment rate also varies amongst the elderly depending upon their area of residence, the more in urban, more with higher education, and more in the richer quintile. So these factors, they do affect the treatment rate also. Then the sensory deficits, visual or hearing, GI, urogenital, and oral problems, they are also important. And as has been discussed by Professor Agarwal sir also, that all these areas have to be looked into for the comprehensive geriatric care. The prevalence of the chronic diseases steadily increases with age, which has been shown more common for cardiovascular disease. One important point which I like to highlight, this is the first of its kind study in which in population surveys, spirometry has been used. An alarming point is that more than almost half of the individuals, 49% of the individuals, had some deficit, restrictive or obstructive lung disease. So there is a need to highlight this poor respiratory health of our older adults. And this has to be looked into in our interventions also. The mental health, of course, is important. And with the increasing age, cognitive decline and depression is seen. And most important point of this study was the use of biomarkers. The biomarkers have been very significant part of this study, and which has shown that high blood pressure, low vision, underweight, they show steady rise with the advancing age, while the obesity and mean grip strength declines with the age. Functional status study is important for older people, and which also highlights the need for looking for the functional decline. And falls and injuries have also been increasing with the age, and the health risk behaviors have also been looked into, and they have studied tobacco use, alcohol consumption, physical activity, and spiritual activity. This is first study where the yoga practice has been evaluated in a survey. So we do see that with the age, there is a decline in the physical activity. So now, coming to this information which we have with us, with LASI, it shows the importance that we utilize this scientific basis for our integrated care of older people. In integrated care of older people, we are looking at the functional ability of the old people and also their intrinsic capacity in the important domains of cognition, depression, nutrition, locomotor functioning, visual or hearing. So I think LASI would give us a scientific basis for adopting the integrated care of older people, looking at these intrinsic capacity domains, and also to look at the functional ability of these individuals by collaborating with specialties like those which are dealing with non-communicable disease, mental health, oral health, eye care, palliative care, rehabilitation, and social care. There has to be a comprehensive plan for their problem to address their problems by involving all these specialties so that we could provide a comprehensive care to the older people. I think the LASI is an ocean, and there is a lot to be gained out of that particular study, and we will keep on dwelling upon that. How could we utilize it for our interventions and our healthcare facilities? Thank you very much.
For a very lucid presentation, and you really pointed out very rightly with respect to health issues of elderly that there are wide regional variations. They vary according to age. There are rural, urban differences. There are gender perspectives. Economics plays a major role. Education plays a major role. And then again, you see, self-reported health will vary according to what their socioeconomic status is, what their education status is, and all of that. And one thing which I liked about that is you conducted the spirometry, and I had the honor of conducting this spirometry in the field settings, but that was during odd even time. And at that time also I wanted to share with you that 1/3 of our Delhi's population is also lung impaired. So, and I can imagine that what would be with regard to, the elderlies in the home care settings, and because this is a very, very challenging task. And again, I know that this is a very, very comprehensive assessment of overall health of the elderly. And as you really said, that LASI is an ocean, and then that reminds me to a quote by Dr. Mahatma Gandhi ji, that we are all visions of change and we are the change makers. And this is the beginning from where we have to start the change, and we carry it forward. And we will see a healthy aging concept very soon, which is already there, but we will see in practice. Thank you so much. Thank you.
Thank you.
So with this, we can go to the next presentation, which is by ophthalmic and eye care needs of elderly. And we have none other than Dr. Praveen Vashisht, who is Head Department of Community Ophthalmology from All India Institute of Medical Sciences, Delhi. So Dr. Praveen, may we have you, please?
Hello, am I audible?
Yes, you're audible.
Hello?
Yeah, loud and clear. You're audible.
Thank you, ma'am. Yeah. So thank you, Dr. Samila, and the entire team. It's really nice that such an extensive survey has been conducted and report has been released. I'll be sharing about the component of eye care. In fact, we also conducted a similar study with a huge sample size of 93,000 population all over India, and I was principal investigator. So I'll be sharing some component of that report. First, I must share the definition of blindness, which is there in our country. Definition of blindness is defined as when the visual acuity is less than 3/60 in the better eye. That means the topmost line in this E, if it cannot be read from a distance of 3 meters, then a person is defined, and it is with the better eye with available correction. That means the vision should be less than this in both the 3 meters. Whereas visual impairment is another component which is commonly used in India. It is defined as when the visual acuity is less than 6/18 in the better eye, 6/18 in the better eye from a distance of 6 meters. Whereas WHO, they have some more extensive definition. As far as blindness is concerned, it is similar. It is less than 3/60, both for NPCB and as per WHO. But for visual impairment, they have divided into 3 other components: severe visual impairment, moderate visual impairment, and early visual impairment. So in this study, basically, I have talked mainly kept as international comparison. So I've used international definitions. So first, we must know that WHO recently released this World Vision report. And as per this report, what they say is globally, there are around 1 billion people who have either near or distant visual impairment. That is nearly 15% of the global population. They have either near or distant vision problem. And the leading cause of visual impairment and blindness are uncorrected refractive error and cataract respectively. So cataract is the leading cause of blindness, and uncorrected refractive error is the leading cause of visual impairment. And the majority of people with vision impairment or blindness are about the age of 50 years. So it is mainly the geriatric population. And presbyopia, which is usually seen after the age of 35, 40 years, there are around 1.8 billion people with uncorrected presbyopia, which is expected to increase to 2.1 billion by 2030. And when we talk about presbyopia or near vision problem, it is another important shocking thing that in India and Southeast Asia region, we have the highest number of unaddressed presbyopia people where reflect this spectacles for presbyopia are required and not being provided. So this national program for under this National Program for Control of Blindness and Visual Impairment, we conducted National Blindness and Visual Impairment Survey. I was principal investigator for this survey. We covered a population of 93,000 above the age of 50 years. And the survey was conducted as per the WHO certified methodology called RAB, Rapid Assessment of Avoidable Blindness. And this was conducted from 2015 to 2019. So I think the people who are here, they can understand how huge is the survey and all the difficulties. Quality care has been taken care of. In fact, this survey has been conducted by a team of AIMS. All these surveys, the 31 districts have been covered from 24 states and union territories. And as per this survey, among the 50 plus population, the prevalence of blindness in our country is 1.99%. And overall visual impairment is 13.76%. In fact, in your survey also, you have shown prevalence of blindness as 2.1%. So it was quite close to this one. One thing which I would like to share with whatever blindness, visual impairment, or any kind of visual impairment, you can see the gender difference. The blindness and visual impairment is everywhere higher among females compared to males. So this is an area of concern, and where we have to take care that gender issue should be taken care of, and females have a higher burden of blindness. Another factors which is very clear and obvious, that blindness is an age-related disease. And you can see in 50 to 59%, the prevalence is just 0.5%, and increasing by age, and 80 plus age group, is 11.6% people are blind. Then urban and rural, we all know that the services are low in rural, so blindness is also higher in rural area. It's 2.1% versus 1.8% urban areas. And it is associated with literacy status also. Among 10th pass, the prevalence is just 0.43%, whereas among illiterate, the prevalence is as high as 3.23%. That means, so all the socio-economic factors, these have been taken care in this study. And you can see the variations in our country. It is ranging between 1.08% in Kerala, Thrissur district, Kerala and Goa, and in Gujarat it is low. Whereas high in UP and in Nalbari is in Assam, and Warangal is in Andhra Pradesh, Telangana. So ranging between 1.08% to 3.67 with an average of 1.99%. We also estimated, this was in 50 plus population, the prevalence was estimated in overall population also, conducting by another survey in 0 to 49 age group. And in overall population, the prevalence of blindness is 0.36%, whereas prevalence of visual impairment is 2.55%. And if we talk in terms of numbers, the total number of blind people in our country at present are around 4.8 million. And among them, 4.2 million, nearly 88% are in 50 plus age group. And overall visually impaired are 34 million, and among them 29.2 million are in 50 plus age group. This is showing about the trends for the last 3 national surveys which we have conducted, the trends of blindness in 2001, 2007, and the current 2019 survey. In 2001, we had a prevalence of blindness of 5.30% 50 plus age group. In 2007, it was 3.6%, and now it is 1.9%. So you can say that the prevalence of blindness, and definition here is less than 3/16, the better eye with available correction. So it is regularly reducing in our country. This is something very positive. As far as visual impairment is concerned, that is PVA less than 6/18 better eye. It was 32% in 2001. In 2007, it was 24.8%, and now it is 13.76%. So something positive to say about the program. As for the goal under the program is concerned, we had a goal that the prevalence should be less than 0.3%, prevalence of blindness. And another important indicator is through WHO as per the Universal Eye Health Program, which is Global Action Plan 2014 to 19. And as per this program, we need to reduce prevalence of avoidable visual impairment by 25% by the year 2019 by taking the baseline prevalence of 2010. In fact, WHO gave the values of blindness and visual impairment for the year 2010, and they expected to reduce it by 25% by the year 2019. And here there are something very, very positive findings. The prevalence of blindness, which was visual impairment, which was 5.3% in 2010, now it is 2.55%. So instead of 25% reduction, we're able to reduce it to by 51.9%. And also in blindness, it is 47.3% reduction. That is from 0.68% to 0.36% during the same period. So it's not only achieved, but we've bettered our blindness and visual impairment figures. But when we look for the causes of blindness and visual impairment, the cataract, which is since the first survey was conducted in 1971, since then, cataract is the leading cause of blindness. And even now at 66%, 2/3 of blindness is due to cataract only. Whereas another important worrying factor is the cataract surgical complication. We're doing huge number of cataract surgery in our country, nearly 65 lakh cataract surgeries per year. But cataract surgical complication also emerges as an important cause of blindness in our country. Another leading cause of blindness which has emerged is non-trachomatous corneal opacity. In 2001, it was just 0.9% overall blindness, but now it is 7.4% of the overall blindness. So these are the things which have to be taken care of. Glaucoma is also 5.5%. On the other hand, the refractive error, which was important cause of blindness in previous survey, now it is just responsible for only 0.1% of blindness. So taking into cataract, whether it is uncorrected aphakia or cataract untreated or cataract surgical complication, this is the biggest reason for blindness as well as visual impairment in our country. And I request all the policy makers that maximum emphasis has to be given on cataract only at this stage of our country. If we can manage cataract in the morning, our health minister also speaking about, they started cataract surgery program in Delhi. And even at this stage, this is the major burden in our country. In spite of doing such huge number of cataract surgery in our country, what we want to say that yes, we are having a very, very good cataract surgical coverage. Nearly 93% of people who are visually impaired, and 74% of people who are visually impaired, and 93% of people who are blind due to cataract, they are being covered for cataract surgery. Still, the remaining portion is responsible for such high percentage of cataract blindness. When we talk about refractive error, uncorrected refractive error, and uncorrected presbyopia, this also has a huge burden. Nearly 11.5% of the population above 50 years, they have uncorrected refractive error, and 74.2% population, they have uncorrected presbyopia, and this needs to be taken care of. Also about diabetes, we also look for diabetes prevalence. The prevalence of diabetes was 11.9%, which is also close to your findings. But we have also seen the prevalence of diabetic retinopathy. It was 16.9% among the diabetic patients. And among them, 3.6% was sight-threatening diabetic retinopathy. So in conclusion, what I would like to share is that currently, as per the survey findings, these are the key areas where we need to give emphasis. One, first and foremost, is the uncorrected cataract and cataract surgical complications. Second, most important is the corneal blindness. Then refractive error, including presbyopia. Refractive error is important cause of visual impairment, glaucoma, and then posterior segment disorders, including diabetic retinopathy. In the subsequent presentation, Dr. Pramila Gupta, she'll be sharing about these component disease and what is being done at the national level for these diseases. Thank you very much. Thank you.
Thank you, Dr. Praveen. And it has been really enlightening presentation. And I'll see that the eye care needs of elderly, despite, the blindness control program being very robust and very strong, still, and I remember whenever I make MCQs with the National Board of Examination, cataract is still the leading cause of blindness. That all of us, we know as undergraduates and as postgraduates also. And let me share with you, I'm also, the president-elect of OMAG, and Dr. Natarajan is a retina specialist in Mumbai who is there, and who is, also president of the Ophthalmological Society. So we keep discussing how, there is a changing, scenario. Now we have got also diabetic retinopathy also, and India is the diabetic capital of the world, and Delhi is the diabetic capital of India. So, I look at your figures with great interest, and I feel that though, blindness control program has done a lot, but still lot needs to be done. And this will definitely form a baseline for our subsequent surveys. So I wish that we are able to see, till the three, subsequent surveys are taking place. So it's a tremendous work, and I feel that we have to be very vigilant about this data, and accordingly we need to increase our interventions because the program is very strong. And let me tell you, we have also had an innovation where at the primary level we have integrated eye and ear care services together. That means we have trained the vision technician for the primary ear care also. So that report I'll be sharing with all of you also. So we can, because our resources, human resources are very less in number. So we have to do with much this thing, with those resources only, with the standardized training. So I think, this has been a real lucid and presentation with lot of way for future. And since, one of the strongest program I see is our blindness control program, but it requires to be, kind of taken at all levels and discussed, because we are now in a changing scenario where non-communicable diseases are occurring more and more, which are going to affect the eye, particularly when you talked of diabetes and also hypertension. That would be. So thank you so much. So are we having presentation by Dr. Pramila now, or we are going to Professor Veena? Okay, so we'll go to Professor Veena Jain, who is Professor and Head of Department of Prosthodontics from AIMS. She's going to talk on oro and dental needs of elderly. So Dr. Veena is here. Professor Veena?
Yes, thank you, ma'am.
Good afternoon. Good afternoon.
Ma'am, and good afternoon to all the colleagues from the different fields. Ma'am, my screen is shared or not? जरा धीरज को भेजो, ये स्क्रीन शेयर कर ही देंगे. तो देखना एक मिनट क्या हुआ, स्क्रीन शेयर करा, पता नहीं अटक सा गया, ये कनेक्टिंग हो जाए. Hello, ma'am, my screen is shared now.
Your screen is not shared. Your screen is not shared.
Do you want us to share your presentation?
That's what I'm telling. Otherwise, we can listen to our presentation. Otherwise,
You can share. I will speak out. अब शायद हो रहा है. Now it's shared, I think.
Yeah, it is shared now.
Yeah. Good afternoon to my moderator of the session and to all the colleagues from the different fields. As I will cover about the geriatric oral dental health status in India. We know the oral health status, especially for the elderly people in India, scenario is not very good. If we see the distribution of the elderly compare the distribution in rural and the urban area, the maximum 80% of the elderly people are residing in the rural area only. While we see the distribution of the dentists as compared to the elderly population, the distribution is reversed. We see the most of the dentists are residing in the urban area. So 80% of the dental professionals dwell in the urban area and render services to just 30% of the urban population, whereas the remaining 70% of the rural population is left with a meager of the dental services. So why there is so much discrepancy? Why most of the dentists are residing into the urban area only? There are so many reasons. Most important is the lack of the education. Many of the elderly or the people don't know what facilities they can gain to maintain their oral health. Secondly, they have lack of finances, and the dental in the any of the life insurance policies did not cover the dental treatment in that, and lack of the social support also many times. And these patient elderly, as covered by the in the LASI report and by colleagues also, these elderly people have many more other general health problem also, and multiple comorbidities. So they need someone who can take them to the dentist for their dental treatment, as the dental treatment is not available in the some many time in the nearby, or dentist, if they, even though they can visit the home, they cannot provide the dental treatment at home. And if we see the other concern is the poor social interaction with the family and the friend. And as I said, educational access and the opportunities are very less, and the potential for leisure pursuit and the consumer protection and having access to the information, what treatment can be gained, how to they can gain the treatment. Now, all these things are missing. If we see further, the status of the geriatric patient as said by the other colleagues also, the number of the functionally dependent or the severely disabled elderly are increasing with time. Not in India, as a global situation is like that only. If we see about the dental disease or the oral disease burden, if we see about what type of the survey is conducted, till now the last survey was at the national level was conducted in 2002 and 3. After that, no survey for the oral health is conducted at the national level. Although survey is conducted at the regional level, as this was conducted by AIMS only in collaboration with Government of India and the WHO collaborative program in December 2007. And beside that, there are meta-analysis, very few meta-analysis. This is a very important meta-analysis by Dr. Chandrasekhar and et al., who had done a meta-analysis of 129 studies which are available onto the internet in the different sites. And according to these studies and this national health survey, if we see the amount of oral disease burden is almost same. If we see the caries is almost 85% in the Indian population and the elderly, and the disease of the periodontal disease overall is 79%. If we see in the elderly, their stake is approximately 30 to 40% periodontal disease. Periodontal disease means the tooth supporting structure is compromised. That is the soft tissue, periodontal ligament, all these are compromised. Sometimes bone is lost, so tooth become loose. And the loss of attachment. Loss of attachment means gum and the surrounding soft tissue become loose. And the fluorosis is reported. Even in Delhi, many regions or like in Rajasthan and many other states where the fluorosis, amount of fluoride into the drinking water is more. So many patients reported the fluorosis. Fluorosis lead to the dental caries and the discoloration. Caries means tooth material is decay off. So these people have very unsightly appearance and cannot use their teeth for chewing and have pain and very discomfort. And definitely the incidence of the oral cancer in geriatric population is less. But if we see the edentulous, on the basis of the different study, approximately edentulous means when all the teeth are lost. That is nearly 29.3%. If we see the LASI report, this also said the edentulous is almost same, especially into the northern state. Like the Himachal Pradesh, the Punjab, Haryana, their edentulous is approximately 20% to 27%. And level of partial edentulous is also very high. Partial edentulous means few teeth are missing, or in many cases we can say only few teeth are present. So according to this LASI report, approximately 71 or 73% of the people have partial edentulism, geriatric patients. And only 33.3% of the patient use toothbrush, especially the geriatric patient, to clean their teeth. If we see the status of the tobacco smoking, that is also quite very high. If we see that, we asked the survey during the survey how many times they do the smoking. Less than 10 times, the approximately 76.2%, by more than 10 times, 23.8% of the people. Tobacco smoking further may it lead to many other problem. It lead to oral cancer. This also lead to the decaying of the the surrounding structure of the tooth. Like these patients have more amount of periodontal disease. Even sometimes the tobacco has accumulated between the teeth. This lead to the caries also. So these are the problem which is encountered. And if we see the studies are lacking a lot. Their only last survey was done in 2003, 2 and 3 at the National Oral Health Survey. Then if we see at the Indian level, who is providing the service, the dental services or the oral health care? They are government sector, they are private sector, definitely private institution and practitioner. Sorry. And maybe the professionals or the dentists are employed by the government, like in defense services or the railway, or the dental services are also been rendered in district hospital and nursing home by the dental wing only. So if we see at the primary healthcare, only limited oral health care is delivered. Why it is so? Because they have lack of facilities and lack of manpower because of unavailability of the dental surgeon as well as essential facilities at the primary health center and community health center in most of the state. If we see beside that, except those in the organized sector like in the government institution, railway and defense, the majority of the elderly population has no oral health securities. And dental treatment, if we see inside, we all know is expensive in private sector and considered optional by majority of the elderly and their care provider. And another reason why they considered it optional, because most of the health insurance company do not reimburse the dental treatment. And even the government scheme like Ayushman Bharat and the CGS did not provide the comprehensive coverage for all dental treatment. Only few dental procedures are covered under the CGS and the Ayushman Bharat. What is the reason for that? Reason is that dental treatment many a time considered as the aesthetics only. Although these treatments are not aesthetics only, they affect the overall general health of an individual. And if our teeth are not healthy, we cannot chew or masticate properly. That again affect multiple systems. So everything is interrelated. We should not neglect the dental treatment for the not only the elderly, for any of the section of the society. Even the national policy for the elderly persons was launched in 1999. This was further revised in 2010, if we say. But in this policy, oral health was not included. That must be included. This is my request. And on the basis of what is available for the geriatric for the oral health, few recommendations which I want to recommend is the availability of the essential oral health services for the elderly at the district level with the provision of dental lab at least to fabricate list removable denture. Removable denture means partial denture where few teeth are missing or complete denture where all the teeth are missing so people are not able to chew their food at all. And the geriatric oral health survey at national level can be conducted to find out the status of the existing dentition, their dental demand, need, barrier, why they are not taking the treatment, what are the problems they are encountering, and the available dental facilities in the different state and the cities, and whatever dental facilities are available, what is their status? The status of the available dental facilities has to be taken care. And we must enable access to dental care for people unable to travel to dental clinics. As we see, many of the, with the old age, morbidity has increasing. But in the LASI report, as sir has said, the major problem is the locomotor disease. These people cannot move. So mobile dental clinic has to be started. And the development of domiciliary dental services, as I said, dentists can visit but cannot provide any service at home. That need multi-sectoral collaboration, and the continuous dental education program can be organized to improve the knowledge, skill and attitude of the health professional as well as the healthcare worker regarding the oral health of the geriatric patients. This is very important. Healthcare worker must be included in all the education programs. And the geriatric oral health must be introduced as separate subject, which is lacking in our in India at the undergraduate level. And as a separate can be started as a separate specialty can be introduced for geriatric complete oral health care, like in many other countries. There are a separate branch for the geriatric name as geriatric dentistry, which is lacking in India. Thank you. Thank you, madam.
Thank you so much, Dr. Veena. I can agree with you no less that basically you see oral health is grossly a very, very neglected problem because of major rural urban divide of the manpower because of various reasons. Another thing is tobacco, which you mentioned. Another emerging component is smokeless tobacco because the study which we are doing is, addressing smokeless tobacco in Southeast Asian region. It is in India, Bangladesh, and Pakistan, along with 8 universities of UK. And I will be ready to share the findings of that. And and we have violated all, kind of components under FCTC. So we need to look at that very carefully. Another thing which you pointed out is that there is limited oral health facility, but it is also lack of awareness, I will say. That is another important thing. And we do have very few skilled dentists at the peripheral level. So that is another thing which you need to keep in mind with regard to, the human resources, and mobile clinic can only serve the purpose to an extent. So ultimately, we need to look at under universal health coverage how our oral health can can reach to the last mile. So these are my initial observations, and I'm sure LASI is going to provide us an important platform for addressing, the oral issues which are.
Dr. Sunila, we've lost you. We can't. We've got you back.
But
Yes, नहीं, मुझे लग रहा है डॉक्टर वीना जैन का प्रेजेंटेशन शेयर है.
Yeah, from Department of Onco and Sushma.
Next is yes. Dr. Veena Jain, you'll have to.
And we have now 2 more presentations in this.
Dr. Veena Jain, you'll have to stop sharing. Dr. Veena, please stop sharing from your end.
Yes, so I can you hear me?
Hear me?
Yeah. So you can start. Do you have a presentation or you'll?
I have presentation and few very
Okay. So
I will finish in time.
Yeah. Very good. Very nice.
So, but I cannot share right now. Can you allow me? Can you allow me to share, please?
Gauri, you have to facilitate. The office can do that.
Dr. Sushma, you're a presenter, so you can start sharing on your own. I think Dr. Veena has not stopped sharing.
Yeah.
Yes, Dr. Sushma, you're sharing now.
So can you see my slides, please?
Yes.
Okay. Yeah. We can see that.
Yeah. So, good afternoon. Thank you very much, Dr. Gauri, Dr. Sunita. Since morning, I am hearing this report and the various presentation in the area of elderly care, and I'm so impressed, and I really want to congratulate you that for doing a wonderful work since morning. I'm really happy and to see all these things, and the second point which makes me happy today is that today you are integrating and you want to integrate palliative care in elderly, and I think this is a need of an hour that we must integrate palliative care in elderly care. So I will give a very brief presentation that why palliative care should be integrated in elderly care. And I'm not going to won't be able to cover all the things that how we can do, but definitely we can discuss it in details in a subsequent time whenever it is feasible or whenever it is appropriate. So magnitude of the problem, I think nothing can be better than LASI report. So there is a huge need of there is a need that the elderly population is constantly increasing in India, and now there is a need that we should start integrating palliative care in geriatric care. What exactly it is? So it basically palliative care. I'm not going to define palliative care, but when we talk in terms of integrating palliative care in geriatric care, means an approach that aims to improve quality of life. Because you must have realized that our elderly, even my dadima, nanima, my mother, always used to say that. I want to live only till the time I can move around. I don't want to be dependent on you. So every single individual wants quality of life. So this is an approach that take care and to improve quality of life of older person. Those who are facing, especially those who are facing with life-threatening illnesses, and those who are near the end of their life. So basically, whenever we plan to integrate palliative care, we are going to take care of those patients, particularly those who are suffering with life-threatening illnesses. Otherwise, also, death is always inevitable. It is not that somebody is 100 years old and we always want that they should live, our elders should live long. But one day, it is a day, the day will come when they will not be with us. But till the time they are alive with us, they should be healthy. They should, at least they should be able to take care of themselves. So this is what is an approach where we are going to concentrate quality of life of this patient. Second point is this helps to define our goals of care. When we integrate palliative care in geriatric care, we will be able to define our goals of care. Otherwise, there is no end to treatment. So if we will develop a program where we can integrate palliative care in geriatric care, we will be able to define our goals of care. And also third point is facilitate a sound process of shifting from goal of functional recovery to purely comfort oriented goal. So goal should be that patient, the person who is with us should be live as best as possible till the time he is there in the world, but with the best quality of life. What are the issues in older people needing palliative care? There are multiple issues, and a few to enumerate is person incapacitated by difficult symptoms and he is homebound. For example, a patient with carcinoma, he is having severe pain, breathlessness, and he cannot come to the hospital. A patient with dementia, patient with multiple sclerosis. There are multiple examples. Those who are at home and they are having intractable symptoms. There we need palliative care. Then, when the patient has reduced functional capacity and bent bound, patient with multiple comorbidity and poor medical support. For example, in villages, I think it is very easy that to be integrate palliative care in home care settings, even in the villages, because there is no need of extraordinary infrastructure is not required. Then frailty, physical and cognitive disorders, poor family support, poverty, loneliness, family caregiver support is very less, and patient is suffering and having intractable symptoms and alone. Person who is approaching end of life, maybe because of the natural disease process or because of natural aging process. So when a person is approaching end of life, means when approaching end, definitely there will be some symptoms, and how we can provide comfort care to this patient is what palliative care is. Advanced care planning also included in this, and dying people and bereavement support. Bereavement support means for people support which we give to the caregivers after their loved one has passed away. So this is a diagram which is universally accepted, that how we can provide continuum of palliative care in the disease process. For example, a patient who is suffering with chronic debilitating condition, definitely there will be therapy. Definitely we will give emphasis that he should be cured, he or she should be cured, and we should have a restorative intent. But as the disease will progress, the person, as the disease will progress, we will integrate palliative care right from the beginning. And as the disease will progress, palliative care will take the leads, and the therapy, definitive therapy, which is we are going to provide for curative care, will become less. And when a person will reach to end of life care, when he will reach to end, definitely we are going to provide care to the patient so that he will live as best as possible with good quality of life. And finally, bereavement care. Bereavement is included in palliative care, that we are going to provide the care to the loved ones, those who have passed away. Basically, it is not necessary that we will go home or something, but definitely if we will provide a good end of life care, automatically bereavement will be better and it will be comfortable, as it will not be a bad bereavement. I can say that it will not be, grieving process will be not long. So most of the time what happens, that why we are unable to provide, it is not that it's a basically palliative care is not an something which, definitely there are specialized palliative care physicians now. MD palliative medicine program is already have rolled in all over the country, but the basic concept of palliative care is already there inside us. Only thing we have to just utilize, and we have to just integrate that concept which already having. This means most of the time we are concentrating on physical problems. When a person comes to our clinic or in the hospital, our whole emphasis is on his or her physical problem: pain, hypertension, diabetes, anything which we can count on. And most of our teaching and training is on the physical problem. But this person is also suffering with some kind of a social issues, psychological issues, any spiritual issues. This is called as total care. This concept was given by Dame Cicely Saunders, and it is necessary that this total care should be an integral part of any geriatric program. I'm not saying that geriatric palliative care program. Palliative care physician will be required for intractable symptoms, and definitely for the help for the patient when symptoms are intractable. But this basic concept that person needs total care, and all four prongs approach and four aspects of the care should be provided to this person. This is the positive outcome of integration of palliative care, that once we integrate palliative care, a lot of family meetings will happen. There will be better understanding of diagnosis and prognosis with the patient and the family members. Patients and family member will be able to make the informed choices, and finally once they will be able to make the informed choices, everything will be transparent and honest, and there will be a better patient physician relationship, which we have lost long time back. So this is very important, that now it's a high time that we should integrate palliative care into any of the program which is requiring, and when patient is suffering with any serious health related disorders, and which when it comes to geriatric population, I think they really suffers a lot with any serious health related disorders. So now my next slide is, I will just summarize in pain in one or two slides, that incidence of pain is huge in geriatric population.
I think in a minute you summarize, Dr. Sushma. That will be okay.
Okay, I will summarize.
Thank you.
There is a lot of myths and misconceptions about pain medications, and when it comes to opioids, it is a circle which can be utilized for safely. These are the things which on a elderly patient wants from us. This is a policy which AIMS has created for end of life care policy and pain policies to provide peaceful, pain-free, dignified end to any patient who are suffering with serious health related disorder, including geriatric population. This is my take home message, that palliative care for older patients is a huge problem, and it's a high time we should integrate. This is my slide which says that reality, that most of our elderly patients die in ICU, which they never wanted. They want to die with loved one. If we will not create a system like this, all our patients will die in ICU. Humanity is integrating humanity in our medical science is must. It is a wonder drug, and this is the declaration which we in 2018 we had a declaration. It was a joint statement by Indian Association of Palliative Care and Indian Academy of Geriatrics, which we have presented in 2018 in National Conference of Indian Association of Palliative Care. So this was my last slide. Thank you very much. Thank you for giving me this opportunity.
Thank you.
Thank you, Dr. Sushma. I think your Delhi declaration actually is a national declaration, I'll say. And again, we all realize that palliative care is a huge problem and humanity is the wonder drug. And I really liked your flow chart where, the family meetings can lead to better understanding, informed choices. And even if they don't have better physician relationships, at least they have better human relationships. Because if we are aiming at improving quality of life, that will facilitate everything and that will have the elderly along with the families, along with the society. So that is the whole idea. The worth of information which we can get from elderlies, I think, is unparalleled. So that is where we need to look at all aspects and especially palliative care, which is so much neglected. And as your last slide really touched me, where you showed an ICU scene, exactly no elderly will like to, lose his life in the hospital setting. They all will want to be comfortable within their whole setting. So that is important part of it. Thank you so much, Dr. Sushma, for a wonderful presentation. And since we are short of time, I'll immediately move to the next one. But it was really innovative and very interesting. So next presentation is by on mental health concerns by Dr. P.T. Sivakumar from Department of Psychiatry, NIMHANS, Bangalore. So can we have Dr. Sivakumar, please? Yeah, he's there.
Yeah. Good evening, everybody. Can you hear me?
Good evening. Yeah, we can hear you.
Can you allow me to share the slide?
You are a presenter, Dr. Sivakumar. You can.
Okay.
ठीक है.
I'm not able to. Yeah. Hello, can you hear me?
Yes, we can hear you, Dr. Sivakumar, but we can't see your slides. Do you want me to share?
Yeah, can you share? Can you share?
I'll try my best.
Yeah. Sorry for.
Is it visible now?
Yeah.
Okay. You'll have to tell me when to change.
Yeah. Is it? I'm not able to see. Yeah. Okay. Yeah. So good evening, everybody. I'm going to talk about the mental health, geriatric mental health concerns in the LASI. So actually, many of my previous speakers have highlighted the importance of mental health, which is actually an integral role, which plays an integral role in the health and well-being and also quality of life. So coming to LASI, it has actually predominantly had a focus on cognitive function and depression as the main geriatric mental health issues. However, it has also other issues like substance use, tobacco and alcohol, as well as sleep problems, pain and functional ability, which are other important issues for mental health. When we talk about mental health, it has a kind of dynamic relationship with other non-communicable diseases, both as a cause as well as an effect. So the mental health problems aggravate or worsen the outcome of many of the non-communicable diseases. Also, many chronic diseases increases the risk of mental health problems. So when we talk about well-being of elderly or older adults, we need to handle these as possibly as an integrated care where both the physical health and mental health gets attention. And LASI has actually immensely contributed in getting a clear data about the nationwide prevalence of cognitive impairment and depression in elderly. This actually strengthens what is already available as part of National Mental Health Survey, as that was not focused on older adults and did not include cognitive impairment. So this is the first data what we are going to have about mental health, including cognitive impairment and depression in internationally comparable data. Can you move on to the next slide, please? Yeah. So the way how cognitive function has been assessed in LASI, it covers actually a comprehensive way it has been assessed. It includes memory, orientation, executive function, as well as verbal fluency, and also it has a composite cognitive index. The cognitive function assessment in a population where literacy is a big issue is a very challenging one. And LASI has attempted to use as much as possible to balance this, as well as to have a necessity to compare, to make it comparable to the available international data. So there are certain issues where some of the tests may not be completely independent of the effect of literacy, but however, this is the best possible attempt they have made. Next slide, please. The cognitive function, what it has been described in the LASI is below the 10th percentile. There are nearly around 10% of older adults have show performance of cognitive function, which is kind of in the lowest 10th percentile. This we need to take into account, which there is a definite effect of age, as well as women has a poorer function, as well as a rural population and an effect of literacy. So this is well known, but it is something like we are having a very systematic data available, which indicates the extent of the problem. Probably the longitudinal data will add more value where we are able to show the decline, because in the current data, some of the impairment could be because of the problem of literacy and other things. But when we show the decline, actually in the longitudinal data, there will be much more very valuable data. Also, we need to see this data along with the functional impairment, which is available. That will give more insights into this. And I think the LASI group also has done additional kind of detailed assessment of cognitive function as another study, about which the data is also available, which is called as a LASI diagnostic assessment of dementia, of which NIMANS also was part of it. Next slide, please. So apart from the points highlighted about literacy, and there is also importance of visual and hearing impairment, and also people not being familiar with paper and pencil tasks. All these things are challenging, and even the environment in which it is assessed. So as you can see in some of the images which were shown, you would not have a very ideal environment where privacy is there for a person to perform a cognitive assessment without much anxiety. So all these things also has a role. Next slide, please. Moving on to depression. Depression is the most important mental health problem in elderly. And here, LASI has used a very systematic method of using both the Center for Epidemiological Studies of Depression scale, which gives a quantitative assessment of depressive symptoms, and also a diagnostic interview, which actually gives a major depression diagnosis. So what they have found is people in rural areas, particularly women and those widowed, and also those living alone and with lower education, have a higher risk of depression. And next slide, please. Also, the kind of nearly around 1/3 of older adults have depressive symptoms, and nearly around 8 to 9% of them have syndromal depression, what we call as a major depression. This more or less is in tune with what we found in the National Mental Health Survey, and also the Global Burden of Disease report from 1990 to 2017, which has also indicated increasing prevalence of depression in India, unlike many other Western countries, where particularly with increasing age, there is not much of data about to show that there is increasing prevalence. But in Indian settings, with increasing age, there is increasing prevalence of depression, which needs to be further studied. Moving on, there are other issues like, again, depression. There is a huge variation across the state, across the sites, similar to many other conditions. India is not uniform, where there is a lot of heterogeneity in terms of the prevalence. But also, most important striking thing is many of them are underdiagnosed, as the self-reported prevalence is only 0.8%. and it is the actual prevalence as per the diagnostic interview is around 8%. So the other important issues are high level of smoking as well as smokeless tobacco, and also alcohol predominantly seen as a younger person problem. Even it is not negligible. Alcohol and smoking can have effect on NCDs as well as dementia risk, and heavy episodic drinking leading to falls and other conditions can also affect the quality of life and the well-being of elderly individuals. And there is also a problem of pain, which again could be a manifestation of depression. In some of the chronic pain, the problem could be depression. Next slide, please. I think this has been already told about various health conditions, and in people who have neurological and psychiatric conditions, only around 3% is or 2% is what is diagnosed, and there's a lot of lack of awareness as well as poor diagnosis which is happening. To conclude, what we see from LASI, there is a high prevalence of mental health problems, particularly in rural women with limited education. There is very low awareness of and access to diagnosis, and high treatment gap. Possibly because of possibility of higher prevalence of mental health problems in those living in residential care institutions also needs to be considered, because many of this survey is unlikely to include people in residential care institutions where the prevalence of mental health condition is likely to be much higher. And there is a need for integrating geriatric mental health care with the National Program for Healthcare of Elderly. And I'm sure there's going to be talks on how the program the mental health program is implemented, and how the NPHCE can kind of integrate with the geriatric mental health care also. And there is also need for community-based interventions to implement mental health promotion and prevention of mental illness, because treatment alone will not be enough. The so-called depressive symptoms, many of which can be addressed by using a task-shifting approach where a volunteer-based interventions can be implemented. There is a good amount of evidence for that demonstrated even in Indian settings. And there is also need to include Ayush interventions to provide a holistic care, which also has a scope in many of these chronic conditions, and also including mental health conditions. There have been studies of yoga being useful for depression. And the most important thing is also to develop a long-term care system and support rehabilitation, and which is also important for healthy aging. Healthy aging is not only for people who have, who did not have disability. People with disability require support systems, and conditions like dementia requires a lot of support in terms of dementia-friendly environment as well as supportive environments. So all these things, I think this data is going to help us to kind of go for advocacy, and then as much as possible, we should be able to work on these things in future. Thank you very much for the opportunity.
Thank you so much, Dr. Siva. It's really, we cannot have elderly care unless we are addressing the mental health problems. And already LASI study has used the standardized scales, which will provide us leads. We are all aware of that there is increasing prevalence of depression in India in all age groups, and especially in elderly, and most of them, they remain underdiagnosed because of either we do not have the system strengthening, we do not have the manpower availability, and also there is low awareness. That is the key thing to access and diagnosis, because people purposely or unpurposely, they do not disclose that they are suffering from different mental health problems, and families at that age, they tend to suppress. So that is where, family education will also play a very, very important role. So supportive environment is the key to everything. That's what I perfectly agree with you. And we need to have systems approach so that our standardized mental health care is provided at all levels. Even our frontline workers should be aware of need for, mental health for elderly within their own settings, because what will be applicable to Kerala will not be applicable to Bihar. So these are some of the important things which I feel that need-based recommendations have got to be made. Thank you so much, Dr. Siva, for this. So with this, we will go to Dr. Day, who is ex-head of Department of Geriatrics with vast experience, and he is going to talk about NCD concerns, particularly in context of cardiac diseases, diabetes, stroke. So may we have Dr. Day, please? I think you need to, he will be able to have his slides, or you will go to share his slides, Dr. Gauri.
Ma'am, he's been made a presenter, so he'll be able to unmute and share his slides. In case he can't, I will do it.
Okay.
I think you are seeing my slides.
Yes, yes, very clearly.
Good afternoon, Dr. Garg and Dr. Sengupta. We are running about 1.5 hours behind schedule.
Yes.
I'll try
All
to
credit to Gauri.
I'll be as brief as possible. I initially thought to give an exploratory, extempore lecture.
Yes.
Gauri wanted that I should speak from slides, so I will try to do that. So I initially from AIMS, now actually unemployed.
Nobody is unemployed.
So we are talking about, actually I changed my topic to chronic disease from diabetes and hypertension, because that's what matters at this point of time. So one of the main objective of LASI was to assess the prevalence rates of chronic health condition in aging population. And I think they have done that pretty well, except a few caveats here and there that I'll be pointing out from time to time. Some of the interesting observations are 24%, nearly a quarter of all 60 plus were reporting poor health, which increased from 12%, that is doubled after within the age of 45 to 59. So looking at my own self, nearly health becomes a major concern after the age of 60. And self-rated health was poorer among older women, uneducated, and those who are not currently working. And Gauri Sengupta should mind it, 53% of older people from Kerala and Tamil Nadu reported poor health. You have a great risk, Dr. Sengupta. CVD was the commonest health problem among older people, which rises from 22% among 45 to 59 to about nearly 1.5 times higher at about 37% the 75 plus age group. I remember our late Professor Wazir told me at the age of 90, the arteries will be anyway blocked or narrow, so nothing great about it. So don't bother too much about cardiovascular disease in the aging population. CVDs remain the number one cause of death among older people. Residents of Goa, Kerala, Chandigarh, Andaman Nicobar and J&K, city dwellers, women, if you are living with your children, you have a higher risk of having CVD. Educated and wealthy people will have more CVD, probably they have money to spend on that. So that's how it looks like. So CVD is a major issue in our population in various age groups. So we found that self-reported diabetes among increased from 9% in between 45 to 59 to 14% in 60 plus. So these are two major illnesses, diabetes leading to predisposing to cardiovascular disease and hypertension. So obviously there is a basis to be worried when about every 1 in 6 in 60 plus will be diabetic. And residents of Kerala, Puducherry, Lakshadweep, Goa, Delhi, etc. And more so in educated class had frequently reported diabetes than the other groups. And diabetes, we somehow, I think, LASI data is incomplete on diabetes because the dry blood samples have not yet been assessed. So we don't have a biomarker assay on diabetes to know how many older Indians actually have diabetes which was not detected. This is a figure you have seen so many times. Not to repeat it again, that we have got virtually every chronic disease in this population as reported in LASI. So chronic disease are our main problem. So what people are doing about that, as self-reported, 26% of households were covered by health insurance, varying from 66% in Mizoram to just 1% in Nagaland. RSBA was very common. So this was before Ayushman Bharat program. So we can consider that there was a background to in which Ayushman Bharat can operate, because people had experience of health insurance provided by state governments and government of India. And some of the good states where 50% of the population were covered with RSBI were Mizoram, Odisha, Assam, Dadra, Nagar Haveli, and Goa. So there is a substantial regional difference in terms of insurance coverage and all reflecting the health system performance. Diagnosis and treatment rates of hypertension, chronic heart disease, diabetes, chronic lung disease, cancer, stroke, joint disease were about 50% among respondents, possibly because by chance or so we got access to some of the very educated and erudite population in our study group. Maybe the whole India is looking like this. Educated and wealthy people had higher rates of diagnosis and treatment as expected because of awareness of disease and their complications. And there are significant different variations in management rates among states and UTIs, indicating functioning of the health system. So obviously, if you are living in a well-functioning state, your chances of getting diagnosed and treated are pretty higher than otherwise. So what we found from this study about health status of aging Indians, some of the interesting observations are over 20% respondents had a family history of the similar illness. So possibly that's why they were aware of the problem and so probably got diagnosed earlier. Aging was associated with decrease in functional capacity in all organ systems. That was obvious from the findings. Prevalence of chronic health conditions steadily and consistently increased. Cardiovascular and lung disease showed a consistent rise. Multimorbidity, which is the essence of geriatric medicine as of now, conditions increase consistently. So there are a lot of data on sleep, pain, injury, angina, hypertension. That is major data on hypertension, obesity, lung function. Grip strength, it is important because the healthy aging, decade of the healthy baseline data shows that grip strength is one of the major determinants of good or bad health. Vision, cognition, affective states. So a lot of data is available. So obviously, in last 48 hours, I have not read anything of this because it's impossible to do justice to LASI by looking at the summary alone. So probably in future times, we will take some good research and then try to look at the data individually. And in fact, the proposed collaborative WHO collaborative center at AIMS will be looking at secondary analysis of LASI data to find out determinants of healthy aging. That we'll be doing in next few months. So what is the take-home message? Aging Indians, I have not told older Indians, aging Indians, because it includes 45 plus population, have significant risk of developing chronic disease and disability. Large proportion of subjects had access to management. 20% respondents had health insurance. There was significant impact of gender, residency, wealth on health and well-being of aging population. There is need for detailed analysis to understand the dynamics of old age in India in determining health and well-being. So what the policy and program for NCDs should be doing, looking at NCD data, we know that we know from the survey that NCDs are the causes of significant morbidity, hospitalization, disability, frail health, increase in the cost of care, and need for long-term care. So they are major issues in health and well-being in old age. Most physicians in our country are aware of their management, and they spend significant time and resources in improving their skill in managing hypertension, heart disease, diabetes. So the individual physicians are well aware of these conditions. That's the bread and butter in most of the clinical situation. Available programs of Government of India need to focus on secondary, that is early detection and treatment, and tertiary, that is prevention of heart disease, stroke, and CKD level of prevention. Let's lay primary prevention to health education program, and the program should rather focus on early detection treatment. That is a bit of a clinical work rather than doing health education alone. So leave health education to school at college education level. We should have provide some system of providing information of future CVDs in 40s and 50s, and also in the public health programs that is being prepared by Government of India. So some kind of a primary prevention initiative should be implemented. I think I have finished in time. Thank you. Thanks, ma'am.
Thank you so much. Ma'am, unmute.
So I'll quickly thank you, Dr. Dave, for your very lucid presentation. And I'll say that 24% of them reported poorer health. But I think if we have deep connect with the communities, we'll find much larger number. And self-reported health amongst poorer women, basically again needs to be, relooked at, because I find that women are caught up in another aspects of life. So reporting of these problems is not an important point of their concern. So here we need to look at whether we need to involve the local help groups or other to reach out to the women. And then you also said that 53% of older, people in Kerala and Tamil Nadu, because you see, more aware the person is, more is the reporting. If you talk of the other states and all that, poorer states, if we talk of Bihar or Madhya Pradesh, or we talk of Uttar Pradesh, because the priorities of day-to-day life are different. So we need to have, our systems much strengthened at that level, which will be, kind of highlighting these problems in a major manner. Another thing which I wanted, the program to take a note of that again, manpower or capacity building is an integral part. We should see that health and wellness center, or above that PHCs or CHCs, where there is a presence of specialists, is able to take care. See, people are not going to come to the district hospitals which are already overloaded, and this is where we need to do standardized approaches with regard to at least few diseases, like when we talk of diabetes, hypertension, or we talk about cardiovascular diseases or cancers, early diagnosis or not. This will play a critical role. So system strengthening, I think that has to be done right from, geriatric is one of the very important components, but we are now thinking of a life cycle approach from pediatric to geriatrics. And somewhere, in order to bring awareness in elderlies, it is also the awareness in youth, which is very important, so that they can carry this message to their families. So as we have overcrossed the time, so we'll be finishing this session, Dr. Gauri, and I, as per my commitment to you. So I think, we have all had a very lucid session, and you can give the closer.
Thank
Hello,
you so
Dr.
much,
Pramila.
ma'am. Thank you so much. I'm extremely grateful to Dr. Sunila Garg and Dr. PK Sen, but more so, Dr. Sunila Garg, you have absolutely floored the session, being absolutely, I'm heartfully thankful to you. At such a short notice, you have managed half my burden. Thank you so much, ma'am. And I'm sure we'll be able to come up with better discourses. Like I had said earlier, this is just the first exploratory one, because the Health and Family Welfare Minister had kind of literally directed us that I want the workshop to be held immediately after the release of the LASI report. So I do agree that experts need time to go through the mammoth 600 pages of that report. And it's like the Bhagavad Gita of elderly, and it has all sorts of data which will be extrapolated in the months to come. We do propose to hold similar workshops on every single domain in an individual manner, in which we will be able to get better culmination of experts and program people and better understanding. So thank you so much, ma'am. We move on to the second panel. That is, how can comprehensive geriatric care services be delivered within the existing national health programs? I feel honored to introduce Dr. D. Bhattacharya, who's the additional DDG and my boss presently in the Directorate General of Health Services, along with Dr. Sanjay Kumar from UNFPA, who will be moderating this session. The reporter will be Dr. Kavita Chaudhary. And Dr. Sunila, you need to mute yourself. Yeah, thank you. Okay, so this session is basically where our program officers of the various programs will be giving their view of, they have been instructed to kind of bring about what all elderly care services are available presently in the program, And in case some new services or some new targeted interventions or mechanisms can be evolved, which may be later on addressed through a collaborative framework between NPHCE and their concerned programs, or maybe partly in their program and partly in us. So over to you, Dr. Bhattacharya and Dr. Sanjay Kumar.
Thank you, Gauri. I think Dr. Bhattacharya, you can start.
Yes, good afternoon. First of all, I must congratulate Gauri for organizing this beautiful day-long workshop. So already we have heard about the excellent findings of LASI Wave 1, which comprehensively tells that what are the needs. Side by side, the National Program for Healthcare Elderly, running for a few years, have already a firm structure in place from the ground level to the tertiary level. And the purpose of this session, when we are discussing, is primarily to know what is existing within our programs available in the DGHS and what are the components pertaining to the geriatric group or pertaining to the senior citizen group, which can be sort of dovetailed, because we know there are a lot of activities are going on in different programs in silos, but why not dovetailing the best part and specifically the part which are confined to this population group into this national program, so that all those activities which are being done, they can get highlighted, and also appropriate use of facility and other things can be done. This was the basic idea. So without losing much time, I will also request Dr. Sanjay Kumar to add something before we formally invite our panelists. Dr. Sanjay Kumar, please. Sir, you please unmute.
Yeah, now it's okay. You are able to listen to me?
Yes, sir.
Okay. Thank you. Thank you. Thank you very much, Dr. Bhattacharya and Dr. Gauri Sen Gupta. As you know that I had been a part of this LASI since its conceptualization, and we were working together to build the survey and data. But I think the time has come to reap the benefit of the findings for improving our healthcare services. And I think it was very nice to listen from 12:30 onwards about LASI and its findings and all. And the previous panel very eloquently they told about different aspects or medical aspects of the geriatric care. But I think this is a very important session, that how are we going to actually address whatever the information which is coming to us from LASI, how the national program is gearing up, not only the NPHCE, but also the other vertical programs. And in a minute, we will listen from our own colleagues from different program managers who will talk about what we can do. With this word, I just also wanted to add one more thing is, in this report, as of now, what we are getting is the levels of chronic conditions and some socioeconomic variations. But I think this provides a wealth of information for us, is to actually see the relationship, see the factors, see the cutoff point when the disease sets in, what are the symptoms and signs. I think a lot more can be done by way of analyzing the data sets. And we from UNFPA will be happy to be part with IIPS and also with the government to undertake and unpack what are the policy implications coming out of this particular survey and findings. So that is the next step. But with this small opening, Dr. Bhattacharya, over to you. I think Dr. Pramila will be the first speaker because she has some appointments. So Dr. Bhattacharya, over to you to take it further. Thank you.
Thank you, sir. As you have said, there is a slight change in the schedule actually. Dr. Pramila madam will invite her to take this first session. And Dr. Pramila madam, as you know, she was our ex-Director General Health Services, long time senior, and she had been managing the program very nicely. So I invite Dr. Pramila Gupta to take the session on eye health services for the elderly and tell us what can be dovetailed within our national program for healthcare of the elderly for ultimate public good. Pramila madam.
Thank you, Dr. Bhattacharya, for giving me this opportunity to talk about the eye care services that our program provides for the elderly. Will you please share my PPT? Who is doing this sharing? Dr. Gauri, who will be sharing my PPT? Okay, then I'll speak extempore. As we all know, eyes are a very precious gift of God to mankind. Kindly share my PPT, please, Dr. Gauri.
I am sharing, ma'am. I am sharing.
Okay.
Just give me a minute.
Okay. So our program, that is National Program for Control of Blindness and Visual Impairment, is more than a 40 years old program. It was launched way back in 1976 and it is well entrenched into the system. Thank you. Well entrenched into the system, and we have our dedicated this thing in districts also, in sub-district hospitals also, at CHC level and in most of the PHCs also. So I'll just give a brief introduction and then I'll come to the services. As we all know, a normal vision is very essential for development of brain and cognitive skills in early childhood, for discerning forms, colors, shapes, and depths of objects, for all our day-to-day activities like education, sports, earning a livelihood, and of course, becoming economically and socially independent. Next, please. So aging affects the eyes also, like all other organs. And if these changes are further aggravated, if the aged person is also suffering from lifestyle diseases, especially diabetes and hypertension. So the most important aging changes that occur in eye are laxity of eyelid muscles, which can cause atropine and watering and dryness of the eyes. Then secondly, because of the sclerosis of ciliary muscles, presbyopia develops because the lens cannot change its focus. That is inability to read near words. Then hydration of lens fibers itself causes the development of cataract, and this is a aging process, blurred vision, and this can even lead to blindness if not taken care of. Then sclerosis of the drainage channels of the eye can cause open angle glaucoma, and if not detected and treated early, it will cause irreparable damage to optic nerve and blindness. And of course, the macular area, which is the most important area for the focusing of light, this also degenerates with the aging. So loss of central vision causing central scotomas and metamorphopsias. So most of the persons seeking or needing help of an ophthalmologist are generally in the 50 plus age group. More than 70% of our patients in our OPDs are 50 plus age group people. And as age advances, the eye complaints do increase. This is also evident from the fact that all national blindness surveys done all over the world are done in more 50 plus age groups. And India did its latest national blindness survey, the rapid assessment of avoidable blindness, which finished last year only. And this also shows that the prevalence of blindness, that is the inability to count even fingers at a distance of 3 meters in the better eye, is 1.99%. And in the overall population is a 0.36%. So blindness is highly prevalent in 50 plus age group, and visual impairment again is 13.76%. Next, please. So the major causes of visual impairment in more than 50 years, cataract is one of the major, most common causes of visual impairment. Coming next is the refractive error, and amongst these refractive error, again, presbyopia is the most common. And as one of the earlier speakers, Dr. Praveen Vashish told, uncorrected presbyopia is a major cause of concern in all the developing countries. And nowadays, cataract surgical complications, including posterior capsular opacification after surgery, causes another percentage, 5.9% of visual impairment. So we are also, as surgeons, we are also contributing to visual impairment. Next. As far as the blindness, no, sorry, prior to this. Previous one, please. The causes of blindness among 50 plus age group, again, cataract leads the show with 66.2% untreated cataracts causing to the blindness among 50 plus age group. Next comes the corneal opacities. Then glaucoma is one of the important factors. Again, posterior segment diseases, including diabetic retinopathy and age-related macular degenerations, and cataract surgical complications. So these are the most common causes of blindness. And most of these causes, that is more than 80% of these causes of blindness and visual impairment, are very much avoidable. That is, they can either be prevented, and by early detection, they can be treated, and the blindness can be cured by simple, effective means. Next, please. Next. So this is our organizational structure of our program. And as I told you previously, our program exists even at the level of PHCs also, and now even at the level of health and wellness centers, where among the 12 packages, the healthcare packages, eye care package is one of the package. So we at the primary level, we have the services of a paramedical ophthalmic assistant available, who can diagnose the very basic eye diseases, who can do a vision testing and prescribe spectacles to any age group person. And of course, they also go to the far off places through mobile units, or they do screening camps through which the patients who cannot reach the district hospital or the other hospitals, they can be then brought in these mobile units to the facilities. Then at the secondary level, besides the district level hospital, where an ophthalmologist is available in most of the district hospitals, and we have a separate eye unit, IoT available at the district hospitals. Besides these district hospitals, under our program, we have a major chunk of NGO hospitals, NGO eye hospitals who work under our program. These are registered NGOs under our program through the district program managers. And these NGOs, either they treat the walk-in patients, and they also conduct screening eye camps in nearby rural areas, wherever their hospital is based. And they bring in the patients and do their major role is in cataract surgery and treatment and diagnosis of other eye diseases. So we are helped a lot by NGO hospitals. And of course, any patient needing a tertiary level care can go to our apex institutions, which are regional institutes of ophthalmology, or any other government medical college. And even some of our NGO hospitals provide tertiary level care of eye services. Next, please. These are the services that we provide for elderly. As I told you, more than 80%, around 80% of our patients are of the elderly age group, and our major chunk of our program goes in, even the grant-in aid from our program goes in for free cataract surgeries. And now for the last 10 years, we are providing free cataract surgery with intraocular lens implantation in 99% of patients. And this facility is available at district, sub-district hospital, NGO eye hospitals, and even private practitioners have been roped in, which do this free cataract eye surgery for our patients. And following this free cataract eye surgery, it is mandatory for a post-operative follow-up on 1st, 7th, and 30th day of surgery. The NGOs are paid only when they do the follow-up and upload the data on our HIMS of the 30-day follow-up period. This, to a certain extent, takes care of the quality in eye care. But for improving the further quality of eye care, we have now instituted the dedicated IoTs in each district. Previously, the district hospitals had a common IoT with other OTs, and there were a lot of incidences of infection causing losses of the eye vision. So now there are dedicated IoTs in most of our district hospitals. Then the other service that we are providing for elderly is refraction and distribution of free spectacles to the elderly. This is done again through our hospitals, even through our PHCs or vision centers. These vision centers are again for provided by NGOs, and district hospital, sub-district hospital, everywhere we provide free spectacles. And wherever we put up the screening camps, there the patients are again followed up and given free spectacles, those who undergo refractions. Then the next facility available in our program is diagnosis and treatment of other common eye diseases like diabetic retinopathy, glaucoma, and vitreoretinal surgery for the elderly. Of course, this is done at tertiary care hospitals. To a certain extent, district hospitals can diagnose and give medical treatment. But if any surgical treatment is required, then they are sent to the tertiary care hospitals. Then, as I told, conducting outreach camps is one of our major activities and is done by district hospitals, NGOI hospitals. They have a chart made up of the monthly outreach camps, and from there they do the refraction there only, provide spectacles, and bring those patients who require treatment at the base hospital, like cataract surgery and everything. Another new approach that we have started, that some of the states have started, is tele-ophthalmology. This is especially helping in screening and diagnosing of diabetic retinopathy cases and other posterior segment diseases, where our ophthalmic assistants or the nurses available there at the PHCs, they can take a picture, fundus photograph, and send it to the ophthalmologist sitting at the district hospital or the medical college level hospitals. And they study these images, and they give the management or the treatment for the eye diseases sitting at a remote area. So that way the patient doesn't have to travel to the apex hospital or the tertiary level care, even the district hospitals, and he can be treated at the PHC level. Only those patients who require further intervention are referred to the tertiary care hospitals. So this is all from my side, whatever we are providing. So as told Dr. Bhattacharya, most of our services are for elderly patients only. More than 80% of our services. Thank you.
So thank you, ma'am, for giving a very comprehensive presentation. And as you said, it's a program for last 40 years. So definitely whatever you said, it is very clear that most of the things are inbuilt. Ma'am, there is one small issue, like
Yes.
presently there is a challenge that the services under the NPHCE need to be taken down to the level of health and wellness center. So how really you envisage that that services can be taken that down as far as the domiciliary as far as the domiciliary services are concerned?
Yes. As far as the domiciliary service is concerned, we have at the health and wellness centers, we have developed training modules for the multi-purpose health workers and for the CHOs also, the nurse or the Ayush practitioner who will be there manning the health and wellness center. We have developed training modules, but they can do only to the extent of screening for eye diseases and diagnosing eye diseases. The common first aid treatment can be given by the CHOs, but for any eye care intervention like cataract surgery or anything, they have to be sent to a PHC for the prescription of spectacles. They have to be sent to a PHC level, or they can call the ophthalmic assistant at the health and wellness center and get the refraction done of the screened patient. But for cataract surgery and any other surgical intervention which requires the services of an ophthalmologist, either a tele-ophthalmology has to be used, or the patient will have to be sent to the district hospital at least.
Thank you, ma'am. Dr. Sanjay, would you like to say something?
No, I think it is very informative. And I think we should also try to see, as what you said, Dr. Bhattacharya, is that how we should take down these services to the health and wellness centers that will be close to the elderly. So probably this is the beginning. I think we should work further with all these vertical programs with NPHC, and we try to bring bridges the gap, and then how we do our service better. That we will build our next system. Thank you very much. Thank you.
Thank you, ma'am.
Sir, with your permission, can I ask ma'am just one small query?
Yes.
Ma'am, I have just one this thing that we have close to 3% as of NSSO data, but as of other data, we have close to 6% bedridden elderly. So can we, can the program devolve some mechanisms for addressing some kind of assessment at the home level itself through PMOAs or whoever it is that you're to train, only for those elderly who are absolutely homebound, who do not have any caregiver or who do not have anybody to be brought even to the health and wellness centers? So that is my submission, in case the program can look into some targeted intervention for such homebound elderly, ma'am.
See, I think the Ashas, if they do a house-to-house visit, the Ashas, And if they find any symptomatic patient, then they can make a register of they can make a registry of these patients, and then our PMOA can visit these patients and give them at least the first aid treatment. Reps which can be which are what should I say, which can be taken to the patient's home. But as far as the surgical interventions are concerned, for that the patient will have to be brought to the hospitals. We will further brainstorm and try to evolve much better options.
Yes,
Thank you.
Thank you, ma'am. Thank you.
Thank you, ma'am, for sparing your time. Thank you again. So now the next session is on mental health services. So I invite our colleague at the DGHS, Dr. Anil Kumar, Alok Mathur, additional DDG. Dr. Mathur, please, floor is open.
Thank you so much, Dr. Bhattacharya. I have a presentation which I would like to share. Yes. Can you see my presentation?
Yes.
ये वाला इससे स्टॉप हो जाएगा. Okay. Now, coming on onto the mental health needs of the elderly, because we have our program, National Mental Health Program, that is there in the country for the, you can imagine, since 1982, when this program was launched. And for the last so many decades, we are there, we are functioning. And our main arm, that is the District Mental Health Program, is a part of the National Mental Health Program, the overall umbrella, the overall program since 1995. So basically, understanding the mental health needs of the elderly, I have a very interesting data to share with you, that over 20% of adults aged 60 and over suffer from a mental or neurological disorder. So this is the kind of burden of mental disorders, or the mental and neurological disorders that are the elderly are facing. So you can imagine 1/5 of the sufferings of the disorders are the mental health related, or the neurological system related. And the most common mental and neurological disorders in this age group are dementia and depression, and which affect approximately 5% and 7% of the world's older population. So this is the magnitude of the problem, and the main disorders you can see are the dementia and depression, and around a quarter of the deaths from self-harm. When the data is studied the world over about the self-harm of the people who report to the emergencies, it is found that around a quarter of the deaths from self-harm are among the people aged 60 or above. So this is related with the suicide prevention efforts that we are making under our program. And mental health has an impact on physical health and vice versa. So as we were hearing Dr. Seva Kumar from NIMHANS, he was also talking about the comorbidities and all. So mental health has an impact on physical health, and it's a vice versa also. So somebody who is suffering from a chronic disease like heart disease or a diabetes, he suffers from, there are more chances of him suffering from any of the mental disorders also, and it's vice versa also. So this is the impact of mental health or the mental disorders in elderly that I have put in the first slide. Now, coming on to the interventions that we have in the field of mental health in the last 5-6 years, we have been able to launch a standalone national mental health policy, besides implementing the national mental health program. As I have said, that we are here since 1982. But in the year 1914, we have launched a standalone national mental health policy. That was a big achievement. And recently, 87 Act was revised, and now we have a new Mental Health Care Act. And all these interventions, besides our program, the Mental Health Policy, Mental Health Act, these interventions, focus the well-being, the mental well-being of the elderly. Besides focusing on other age groups, we focus on elderly mental health also, their well-being. Now, as I said, this program is there since 1982, and the overall aim is to address the huge burden of mental disorders and shortage of qualified professionals in the field of mental health. And we have this aim with us, and we have a number of components, strategies, actions under the program, which try to attain the aim of fulfilling the shortage of qualified professionals and providing the basic mental health services to the needy. Now, coming to the components of our program, we have basically broadly two components. One is a tertiary level component, through which we try to enhance the number of postgraduate level seats in all the 4 subspecialties of mental health. The 4 subspecialties are psychiatry, clinical psychology, psychiatric social work, and psychiatric nursing. And the second component is district mental health program. So through this program, we provide services at the district, hospital level, and sub-district levels of the government facilities. And I will be focusing more on the DMHP because through tertiary level scheme, our aim is to enhance the number of PG seats. So that is irrelevant for today's talk. So I am focusing more on a district mental health program, through which the components of this program is the components are the services, the training, the IEC, and monitoring and evaluation. And through the services that we provide, the foremost is the outpatient and inpatient service, through which we conduct OPDs, and at many places in district hospital we have standalone beds earmarked for mentally ill. And besides that, we have outreach services also. Our teams conduct camps at the CHCs and PHCs and at different places in the community. And besides that, the patients, the complicated patients are referred to the APEX centers also. Besides that, we provide counseling services, the screening services at the PHCs and health and wellness centers levels, sensitization, and the most important service or the component of our DMHP is training the healthcare personnel. Besides training the doctors, the non-specialist doctors, we train the psychologists, the social workers, the nurses, so that these people can be stationed at the district mental health at the district hospitals and CHCs or PHCs, and they can at least detect these mental illnesses early and provide the management to the common mental disorders. So this is a very important a part of our district mental health program, through which we provide short-term training. Now, last but not the least, we organize awareness camps through our IEC component, and we try to involve the community with all our efforts under the program. Now, recently, this has come into the forefront, the psychosocial interventions, which is also a part of our district mental health program. During this pandemic, our teams have been providing psychosocial intervention, psychosocial support, mental health support to the needy, to to those who are suffering from COVID-19, to the healthcare workers who are treating or managing those patients, all categories of people, we are providing mental health and psychosocial support. Coming to that, the elderly group, we, through our program, we are providing memory clinics. Many states have come forward and they have proposed in their PIPs for establishing memory clinics. And these are for taking care of pre-senile dementia. And there are also a number of states who have come forward for a number of interventions related to suicide prevention. Because as I have said in my first slide, there are a number of elderly who try to self-harm themselves and they present to the emergency services. So these two interventions focus mainly on the elderly, the memory clinics and the suicide prevention initiatives that we undertake under program. And of course, the psychosocial support that we are providing during this pandemic and in any emergency situation, like we have a national mental health helpline in which we have created a separate group for elderly so that they can have, without any hindrance or without any much ado, they can just straight away call the helpline. So they have a priority and they have a separate group under this national mental health helpline. And besides that, we have a IEC material for them for providing psychosocial support. And we have certain, guidelines, IEC material, a number of things focusing on, especially on the elderly and during this pandemic. So sharing with you few IEC material that we have prepared. This is something in general that we have prepared: identification of mental illness in adults, and depression, one IEC material on depression, then dementia, you can see. So these we keep on, circulating on the various platforms of social media. We had undertaken a number of campaigns recently, and this is about the promotion of mental health for a stress-free life. Yeah, this is the, a kind of IEC material that we have prepared, and I have culled this material out, especially for the, for the elderly. So thank you so much. Thank you. That's all from my side.
Thank you, Dr. Alok Mathur, for giving a very lucid talk. First, I will invite Dr. Sanjay to give his comments. Dr. Sanjay, please.
Thank you, Dr. Mathur. I have just one suggestion or maybe clarification from you. I think you have well laid out your program, that how much is the services and even outreach. For example, you provide the IC and other things, and the glimpses we see that. My clarification question is it possible that we should also try to screen a little bit more about those who are depressed and those who are at the verge of, developing, mental health kind of a thing? Why I'm saying this is that I think in LASI survey, or also before that in other survey which we did in India, we had used a screening question which is called GHQ, just to understand, what is the level of depression among elderly. And if we train our health worker or outreach worker to at least, find out these kind of, screen out and then refer to the service providers, will it be useful? That's what my question.
Yes, it's absolutely useful. Under the Health and Wellness Center program, CPHC, part of Ayushman Bharat, we have a CBAC form, which is used by ASHA, and we have a few points, PHQ2, especially 2 points. We have inserted 2 points just to screen depression and anxiety, these kind of things, so that these problems can be detected early, and such people can be referred to at least to the district hospital where a psychiatrist is stationed in our team. So this is the kind of thing that, we have already envisaged the screening form. We have incorporated few points related with mental health in that. and that is going to be used very soon through the CBAC forms in all the 1.50 lakhs health and wellness centers that the ministry is going to operationalize very soon.
Dr. Mathur, I have one thing to say. As it is very clear that in the geriatric group, in the senior citizen group, there is apathy in the families also for bringing them to the centers. Also, there is issue of stigma associated. But because within the NPHCE, because we have a very dedicated structure now available in the form of OPD in the district hospital, in the tertiary hospital, even down to the PHC level. So can something be done for these people, some dedicated services through your program, or some sort of counseling on those specific days? But what I feel is most of the problems, as you say, 20% depression, dementia, they're unable to counseling in a significant manner. So one thing is this, that can something be done in those dedicated OPD days to do something, counseling sort of thing for the targeted group. And second is like within the health and wellness center concept, where the NPHCE needs to deliver the services, there are provisions for community meeting. So this is a second suggestion. If the mental health program can really sort of give an input, because through community health meeting also a lot of inner guilt, inner problems gets sort of dissuaded. So you may please give your thought process to it for better utilization of the services.
Absolutely right. In fact, we have a clinical psychologist for giving specialized counseling or psychological input or the support to the treatment that a psychiatrist is giving. So we have a team there, a mental health care team at each and every district, and clinical psychologist is essential part of that team. So as far as counseling is concerned, the counseling is taken care of by the clinical psychologist, and besides that we have a provision of a clinical psychologist at taluk level hospital also. So many states are coming forward and taking support of having a clinical psychologist at taluk hospital also. So in a way we are expanding, and we are in fact trying to percolate all our services from district hospital level downwards. So this is the kind of infrastructure that we are trying to create in the form of expansion, by providing not only the psychiatrist specialized treatment but counseling also by having a clinical psychologist.
So thank you, Dr. Alok, for sparing your time and really telling us about the major issue. Thank you. So now we go to a issue which is also very common in elderly, ear problems, and we have with us one of our junior colleague, Dr. Sunny Swarunkar, who is in the DGHS only. I'll invite Dr. Sunny to please apprise with the latest issues being addressed in the program. Sunny, please.
Yeah, thank you, sir. Thank you so much, sir. And on the behalf of Dr. Sudhir Gupta, as he is busy in the another meeting, so I'm presenting the National Program for Prevention and Control of Deafness, what we are doing for the elderly in this program. So as far as we all are aware about we have a program under the umbrella of NHM, and from top to bottom, national level to the village level, we have an entire health system. And under this health system, we have the dedicated sub-district hospitals, district hospital, medical college, and all these are services are provided under the NHM. And apart from other services, the deafness, the ENT services is also the part of these services. If we go in the history, this national sample survey was done the 50th round in 2002. So what we have learned that it's disability due to hearing is the second most common cause. And if we see the prevalence in country, that is 6.3% in India of deafness. And the prevalence of sensorineural hearing loss, which is 2 to 3 per person per 1,000 live births in India. And the common cause of hearing loss is called earwax, CSM, serious OM, and bilateral genetic disorders, infectious and non-infectious, and other. But if we see the age-related hearing loss, which is called presbyocusis, which is related to the age, and most affecting age is more than 65 years, which is common in the both here, affecting equally, which is due to gradually loss, which is related to age only. And the challenges in this, the hearing loss is there, and the elderly are not enjoying their life, enjoying talking, they can't, and leading to feeling of isolation. Even some of the problem is there, the doctor's advice and some phone calls are there, so they are not follow with these challenges. So under the NPHCE National Program for Prevention and Control of Deafness, it is launched as a 100% centrally sponsored scheme during 11th 5 years plan and piloted in 25 districts. The expansion of these districts up to currently in 595 districts as of now. And we have some objective under the program, that early identification of diagnosis of treatment in the all age group, including elderly, and preventing avoidable hearing loss on account of disease or injury. And apart from this, we are providing the rehabilitation services of who have found hearing impairment. The various components are in the program that is related to our manpower training, capacity building, and service provision regarding early detection, management, and rehabilitation. And we are providing IAC and BC services. These are the various strategies of the programs, and I'm not going to that much of detail. The most important part are in the program that the person who impaired due to hearing loss and found is eligible for to provide the hearing aid. Under the scheme of ADIP scheme, the scheme for assistance to disabled person for purchasing fitting of aids appliances. So with the collaboration of Ministry of Social Justice and Empowerment, this hearing aid are providing to the elderly or the person who is eligible for this. Apart from this, the most important component which is in the health system is our comprehensive primary health care, and the ENT care is also part of this, apart from other ophthalmic services. So in these centers, we are providing the examination of the ear and under the health and wellness center, and if the person found suitable, so ADIP scheme under we are providing the hearing aids. These are some data of the past year that more than 4 lakhs cases were examined, and the person who have referred for the rehabilitation, that is around 72,000, and the hearing aid fitted is around 24,000 the last year. These are the districts, year-by districts, which have implemented the program now. And we have National Institute of Speech and Hearing, which is autonomous body and under the Ministry of Family Welfare, and providing technical support and services for the program. There are various state level activities which is implemented under the program, and district level also. With the related to the district hospital, we are providing the support for the manpower also, CNT surgeon, audiologist, audiometric, and instructor for the hearing impairment children. But I want to explain that there is primary level activities. Under these, we are providing the services for who need. The training has been provided in the label of Asha, Anganwadi worker, multipurpose workers, even school teacher to provide the services under the program. And we have also have a collaboration with the Rashtriya Bal Swasthya Karyakram. Under this, up to 18 years of children, we are providing the services. For the case management, we have a secondary level activities at district hospital. These are the flow of clinical services where the elderly can go there and take the services of our ENT specialists. And every year we are celebrating our wearing program awareness campaign on 3rd March. And we have the institutional framework also, which are monitoring the program at the top level to bottom level. And if at the village level, we have a village health and sanitation committee, which is responsible for the all implementation of the program, and we are providing the services with the training for the all health services for the multipurpose worker and all officers related to panchayats. These are the various activities for public awareness, which is have been done in the at the national level. The last year's glimpses where our Honorable HFM were present for the World Hearing Day on 3rd March. And we have state level activities which we celebrated. And really we need to protect our ear from the high volume, and if there is any noise, we have to protect all those things. Yeah. Thank you so much for attention, sir.
Thank you, Dr. Sunny. Dr. Sanjay, please, your comments.
Okay, thank you, Dr. Sunny, for giving the overview. And I'm so happy that you are collaborating with Ministry of Social Justice program of providing the aids and appliances. And I was part of that program development. It was a challenge for us actually to get this particular aid inside because of the cost concerns and other things. But I'm happy that it is happening, and yes, we should take it even further more height. So that's no more comment, but glad to note that things are happening. Thank you.
Thank you, sir.
Sunny, I have one suggestion.
Sir,
Sunny, I have one, not suggestion, but an observation also. Because when I was in Delhi government, our present Honorable Minister started first the Shravan Shakti Abhiyan, which is now the national campaign actually. We are part of it. So because now, because as you say, it is the second most common disability, it is well known. And within the senior citizen group, this is a very perceptible problem. So can you devise, may not be now, but over a period of time, at least something at a community level awareness campaign, which can lead to, early diagnosis. And because sometimes what happens is when it's done on a large scale, many of the people who are in the periphery are left out. But because the present health and wellness center concept coming up is very much focusing on having community awareness campaign. So if this can also be built in, so there will be multiple sort of campaign all over the country over a different period of time, and leading to ultimate aim of public good actually.
Yes, sir. Definitely, we should not be restricted to only the World Hearing Day. It should be done throughout the year, so that the community should aware and take the opportunity and take the all services which is under the health system. Yes, of course, sir. Thank you so much.
Please see. And Dr. Gauri has a point.
Sir, thank you for it. Dr. Sunny, I have just two questions. Firstly, as far as the NPPCD is concerned, how is anybody getting the benefit of EDIP scheme? Like if suppose somebody is diagnosed as requiring a hearing aid, maybe at district hospital, at CHC or PHC, how is NPPCD ensuring that they are getting the hearing aid through the EDIP scheme? That is my first question. And my second question is, you said that they are sent for rehabilitation. So many people have been sent for rehabilitation. So where are we sending these people for rehabilitation, and what kind of rehabilitation services are available?
Thank you, ma'am. Ma'am, basically at the district level, we are providing the hearing aid fitting services, and the people who are found diagnosed and eligible for the hearing aid. So at the district level, we are providing their services. And related to rehabilitation, the program we at the district level itself, we have some the guidelines to rehabilitate the people, like some audiometry mechanism, and under the supervision of the clinical and other services, where we are rehabilitating the patient now.
So this is at the district hospital, within the district hospital, that
Yes,
we are
yes.
getting people from Ministry of Social Justice or Department of Social Justice coming and delivering the hearing aids?
Yes, ma'am. Yes.
Okay. So, and the rehabilitation is happening at our district hospital, or is it at their DDRCs?
No, no, ma'am. In the district hospital itself.
Okay, fine. Take it. Thank you.
Okay. Thank you, ma'am. Thank you so much.
Sir, unmute.
Thank you, Dr. Sunny. So now we have another important topic. As you know, oral health is a very challenging subject in this age group. So I invite Dr. Ankita, who is consultant in National Oral Health Program, to please address. Dr. Ankita, please.
Thank you, sir. The program is looked after by Dr. Sudhir Gupta sir and Dr. L. Swasticharan sir. So on behalf of them, I'm presenting, sir. The burden of oral disease has already been described by Dr. Veena Jain in detail. So I will be describing the efforts done by under National Oral Health Program to ensure quality oral health care services for the elderly. Is my screen visible to all? Okay, thank you. So National Oral Health Program, it has been launched in year 2014 to strengthen the public health facilities of the country for an accessible, affordable, and quality oral health care delivery. The objectives of the program are to improve the determinants of oral health, to reduce the morbidity from oral disease by strengthening oral health services, to integrate oral health promotion and preventive services with general healthcare system, and to promote public-private partnership. The program, under the NHM component, support is being provided to states to set up at the district hospitals and below. Support is provided for human resources, surgeons, dental hygienists, dental assistants, and for the purchase of equipments and consumables for dental procedures. Support is also provided for training and IEC activities. Till now, 3,650 dental care unit has been approved under NOHP across 36 states and UTs. Apart from providing dental care, NOHP is training the dental surgeons in NOHP dental care units to provide tobacco cessation services to those who want to quit tobacco. And once the state has saturated all their health facilities with dental care units, then they may propose for special care also, in which the provision for establishing dental lab to provide complete dentures and removable dentures to the patient are there, and they can propose for mobile events. Is IC materials for developing training materials and conducting workshops for capacity building. Now, I would like to put some light on the efforts done under National Oral Health Program to ensure quality oral health care for elderly. A National Resource Center for Oral Health Care of Elderly has been established at Oral Health Science Center at PGI Mer, Chandigarh. The key deliverables of the National Resource Centers are to establish a model geriatric dental clinic with geriatric-friendly environment with all the specialists, that is prosthodontist, periodontist, endodontist, community dentist, nutritionist, psychologist, under one roof. To integrate with geriatric medicine department, to develop standard operating procedures and guidelines for establishing such services at other institutions across the country. So our National Resource Center will be developing standard and guidelines so that we can implement such model geriatric dental clinic across the country, and provision for free subsidized oral health care for institutionalized elderly. The second key deliverable is to develop IEC and training modules, especially for geriatric oral health care, to develop manual for appropriate training of the caregivers. The third key deliverable of National Resource Center is to develop a knowledge hub for geriatric oral health care, to develop a database on relevant researches, to identify global evidence-based best practices for geriatric oral health care and suggest their adaptation in the Indian context. Carrying out operational researches for provision of affordable and quality geriatric oral health care. Next key deliverable from our resource center is to build capacity of states to support other institutes in establishing exclusive geriatric dental services, to provide consultation and support relevant researches in this domain across the country, and to integrate the efforts of National Oral Health Program for healthcare of the elderly. Another project I would like to reflect to share is AMMA project for providing comprehensive oral health care for elderly. Under this project, objectives are screening of the old elderly people are done at old age homes and senior citizens recreation centers, and other oral health promotional activities like health education and toothbrushing demonstration is being done. IEC materials specifically targeted to elderly population is being done under this project. Secondary care treatment services with child dental van is being provided to elderly population, and oral rehabilitative services by providing dentures to them is done under this project. So in the near future, NOHP is planning to such projects in all the states. And we are also looking forward for capacity building of states to provide exclusive geriatric dental services with the help of our National Resource Center. This is from National Oral Health Program. Thank you.
And I think there's a lot of things also was not in my knowledge. And as you said that many of your programs are already integrated toward geriatric care. So nothing more to say. I'll just request Dr. Sanjay to add.
Okay, thank you. I think one of my observation, not only for this program, but maybe a few other programs, is that it's actually reaching out to the district level, 500 districts, 700 districts and all. But given the vastness of our district, one district is like one country, one other European country, and the distance wise, and particularly the vulnerable population like elderly, to reach out to even a district hospital. So probably that's another challenge, I will say socioeconomic challenges for accessibility of the services. So probably in the next phase, how do we actually try to expand these services to at least sub-district or CSC level, if not at the primary healthcare level, all these specialized services, and with provision of, mobilizing people, screening and identifying and referring them to the nearest centers. So something like AMMA clinics or AMMA project in Delhi, which was just shown, probably these kind of a mobile unit could be one of the things now we can think of. So not a very particular question here, but together we will let's discuss further in a next group meeting, is that how do we actually expand those things to make these services available nearer to the elderly. That should be our goal. So that's okay. Thank you.
Very pertinent, sir. Very pertinent, because how really it reaches to the masses actually at ground level. So Dr. Ankita, thank you.
Thank you, sir.
You've done a good job. So now the next session is on palliative care services. This is also a very important, challenging area. Palliative services, what I have seen outside is through hospices care, which is not much available. Like in Delhi, we have one Shanti Advedna near Safdurjung Hospital, where any person need of that support care can just go, and if there's bed available, they give it. But what I see in the community with senior citizen in the home with bedridden, it's a real challenge. So I think, and Dr. We'd like again invite Dr. Alok Mathur to give his opinion, give his sort of insight that what is being thought about this challenging field. Before I invite Dr. Alok Mathur, I will request Dr. Sanjay to add anything in this pertinent issue before we invite Dr. Mathur. Dr. Sanjay, please.
No, I think this is a very, very important aspect of that. And there are certain models which we have seen in Kerala and where it was taken to the community, like, through the PRIs and other things. So probably that model is there, but I think there are challenges even for replicating those models. But let us try to understand what are the government program and then how do we take it further.
Dr. Mathur, please.
Yeah, thank you so much. And I agree with you. This is a challenge. This area of of providing comprehensive health care to the people, providing palliative care to the needy is a challenge. And first of all, the people find it difficult to understand what is palliative care. So let's see what is palliative care. Palliative care improves the quality of life of patients. And not only it improves the quality of life of the patients, but also the families also of their families also. So who face challenges associated with life-threatening illnesses, whether the challenges are related to the physical, psychological, or the spiritual needs of the patients. So this is about the palliative care, and the good thing is that it takes care of the caregivers also, the family members also who are providing the palliative care or the medical attention to them. Now the need of palliative care, you can imagine the need of palliative care is huge. The chronic patients, the life-threatening illnesses, those people who face life-threatening illnesses, life-limiting illnesses. The number of such patients, such people is huge in our country, around 3 million patients with cancer at any point of time, an equal number of patients with other incurable diseases, coming on to the HIV AIDS, the number of people there, and above all, the rapid increase in the number of aged population, because now we are talking about, focusing on the elderly population. So the rapid increase in the number of aged population, the highest number of patients in the need of palliative care in future will be from the elderly terminally ill. So right now also we have quite a huge chunk of people who need palliative care. The chunk of people come from the elderly segment. So this is the magnitude of the problem, and we are focusing very much on the palliative care. अरे यार उनका फोन आ रहा है मेरे पास, चिंता ना करो, मैं अभी एक प्रेजेंटेशन कर रहा हूँ, उसके बाद बात करूंगा. Now these are our program, national program for palliative care, is operational for the last 4-5 years. To be very precise, it was launched in the year 2013-14. And it is a part of National Health Mission, and it's at the two level. It has a two component. One is creating an administrative administrative cell at the state level, which can manage the activities or the interventions in our program in all the districts. That is called the administrative wing, or the creating of NPHCE cell there. And the service delivery is envisaged at each and every district, in each and every district hospital, in the form of providing OPD and IPD services, referral services, home-based palliative care. That is very important, that we are envisaging to roll out, in all the districts of our country. And besides that, the training. So these are the 4 sub-components on which we are focusing at the district level. And at the HWC level or the CPHC Ayushman Bharat level, it is a package, one of the 12 packages under CPHC. Along with geriatric care, palliative care is also one of the 12 packages. And through that package, at the most peripheral level, we are focusing on identifying patients who need palliative care. Basic nursing procedures. We have already developed training manuals for CHOs, community health officers, multi-purpose workers, and ASHAs, community health workers. So in giving basic nursing care to those who need palliative care. Besides that, we are focusing more on, teaching or training few basic skills to the family members also who stay, all the time with the patients who need palliative care. So this is our, target to teach some basic nursing, skills also to the family members. Besides, teaching the training the community health workers at the most peripheral level. Besides that, the psychosocial and spiritual support that we provide under our program, home-based palliative care, referral services, bereavement support, and community awareness. Now, coming to the specific elderly care needs under the palliative care, as I said, the NPHCE ensures delivery of pain and palliative care services for all. And the elderly population is one of the, is in fact the largest segment that we have as patients, those who need palliative care. And home-based care, it's very apt for the older people with mobility limitations. Those Dr. Gauri was asking about, those who are elderly who are homebound, to Dr. Pramila Gupta for providing eye checkup and spectacles, etc. So in our program, it's inbuilt. Providing home-based palliative care is inbuilt, and we try that each and every person, especially a bedridden patient, should be provided home-based palliative care as soon as possible, especially at least by the trained nurses, if not possible by a trained doctor. And the care includes the psychosocial. As I said, it's a whole spectrum of services that we provide through palliative care. Not only we take care of the physical problems, the physical symptoms, alleviating the symptoms physically, but we take care of the psychological support, the spiritual aspect also, and bereavement services also we provide, and it addresses the caregiver burnout. Like I said, it not only we take care of the patient, the needs of the patient, we take care of the caregivers also, their mental health, their psychological support, the social support, everything. Now, the challenges that this population, this segment faces, specifically, when we deliver palliative care under our program, is that population, as we know that the population ages, the pattern of diseases that people suffer and die from also changes. Like we have noticed in the last few decades that increasingly more people are suffering from chronic diseases. So we have more and more, need for providing palliative care. Many older people suffer from several conditions together. This is the uniqueness of this segment. The elderly usually suffer from several conditions. One person suffering from osteoarthritis, cataract, loss of hearing, a number of things, number of problems in one person. Usually this kind of unique situation that we don't see in other segment or other category of age groups. The cumulative effect of these may be much greater than any individual disease and typically lead to greater impairment and needs of care. So this is a unique situation, and accordingly the palliative care needs also differ in this segment. The older people are at greater risk of adverse drug reactions and of iatrogenic illness. So this is also a unique thing that this segment of people, they are at greater risk of adverse drug reactions and iatrogenic illnesses also. And the minor problems may have a greater cumulative psychological impact in older people. This is a reality Even if they suffer from minor problems, they psychologically think that something big has happened. And very often the real needs of older people are not taken into consideration. Pain, physical suffering, helplessness, loneliness, and marginalization can too often become part of everyday experience in the final phase of life. So this is a reality, and we need to take care of the people of this age group, in a very sensitive way, so that all these challenges can be overcome through our program. Thank you so much.
Thank you very much for enlightening us. I have just two small clarifications from you. One is that regarding home visit, what is the frequency which we have once a week, or what sort of frequency they visit? Those who really need it actually.
Actually, we have envisaged that a home-based team should be constituted from the palliative care team that we have stationed at the district hospital, and that team should visit homes every 2 days in a week. Twice in a week they should go and visit the homes of the people. But through our district level team, we are not able to fulfill the home based palliative care needs 100% in a 100% way. That's why we are focusing now more on the health and wellness care centers now, because those people who man the health and wellness care centers, these are the CHOs, ASHAs, and multipurpose workers. They are stationed very close to the homes of the people. So we really look forward to health and wellness centers through CHOs, ASHAs, and multipurpose workers to provide home-based palliative care, though we are providing this care through our district hospital teams right now.
Thank you, Dr. Mathur. Dr. Sanjay, you want to add?
Yeah, I think just the next question, the way you asked is that, of course, Dr. Mathur said about that, what is the frequency of visit? But the question is how you identify, there could be chances of many elderly persons or even otherwise needing these services could have been missed out. So what is how do you actually identify, register them, and then the team goes? And your
yes, absolutely.
Which you said that,
absolutely. For identification of such people, we have incorporated the checklist in the operational guidelines of the health and wellness centers. So the ASHAs or the multipurpose health workers can go through that checklist and identify such patients who need palliative care, and they can just, if possible, they can just provide some basic comfort to the patient then and there only. Otherwise, they can always refer such patients to the higher facilities.
So good. Thanks to know that there is a well-structured program, and then yes, there are challenges. You have also said that there are a lot of challenges, but at least the program is there. And then with the health and wellness center and with other, grassroots workers engaging them, probably we can further work together to improve it further. So that will be nice. So at least the program is there. We don't have to start a new program, but only thing we have to strengthen those programs. That would be the need of the hour. Thank you.
Thank you, Dr. Mathur. First of all, sparing time twice. You have to come twice. Really thankful to you. So we move on to the next topic, that is NPHCE. It's a very flagship program of Government of India. It's a very large outreach, starting from cancer to cardiovascular to stroke. And we have our close junior colleague, Dr. Pradeep Khasnobis, who will tell us about what is being done and how the elderly age group is being targeted. Dr. Pradeep, please.
Thank you, sir. Thank you for giving me this opportunity and giving the opportunity to the program. So I will share the slides. Is it seen over there? Are the slides seen over there?
No.
Not yet.
Not yet.
If you want me to share the slides, please do let me know, Dr. Pradeep.
Yeah. Just let me try once more. Are these slides seen?
No, I'll try.
Am I seen over the slides, or then we can just go ahead with request to Dr. Gauri to share? Not seen. Sorry for the inconvenience caused. So should we start?
Yeah, please go ahead. We are able to see.
Okay. Thank you, sir. So when we talk about NPCDCS from morning onwards, we have heard a lot, really a lot regarding the prevalence of diabetes, hypertension, cardiovascular diseases, and cancer. So before we go into, we have some basic slides, and then subsequently I will be just highlighting exactly what our program looks like. So when we talk about per se the health and health intervention and the holistic approach. So when we talk about health is a state of complete physical, mental, and social well-being, and not merely absence of disease or infirmity, which we have learned from the day when we started our medical studies. So when we talk about the holistic approach of health and health interventions, there are four basic pillars on which we are working upon. Basically, the promotive, preventive, therapeutic, and rehabilitation. So when we talk about the promotive aspects, it is avoiding the risk factors like no use of tobacco, harmful use of alcohol, drugs, to be physically active, healthy eating, work-life balance. When we talk about the preventive aspect, we are talking about more toward the physical activity like walking, running, cycling, swimming. Creative activity like writing, singing, dancing, painting, emotional stability, laughing, clapping. So these are some of the things which we need to do for a preventive aspects for the NCDs. When we talk about the therapeutic and the rehabilitative aspects, this is more important, especially when we are talking about the elderly part, the disease-specific treatments that needs to be taken care of. Then regular checkups at the health centers and providing the needed treatment, palliative care, disability care like the foot surgeries and others, what we do for the diabetics, and psychosocial supports, which we had already heard a lot since my previous speakers. And I really should be thankful for all the organizers for giving me the last slot, because I could just always relate to my previous speakers. They have talked a lot on all these aspects. So that made my life very easy for a just move ahead with. So when we talk about the major NCDs and the risk factors, we move by 5x5 approach. The 5 diseases, which are the cardiovascular diseases, chronic respiratory diseases, cancer, diabetes, mental and neurological conditions, and the risk factors like unhealthy diet, tobacco use, harmful use of alcohol, physical inactivity, and air pollution. So this is what we are mainly harping upon. So when we talk about the NCD and the socio-economic developments like globalization, urbanization, aging population, and poverty, this all basically all leads to a cardiovascular diseases, diabetes, cancer, common mental disorders, chronic respiratory diseases. These are some of the things that happens. This has also been compounded by the intake of tobacco, alcohol, stress, physical inactivity, and unhealthy diets. What we lead to? That we are having the NCDs that leads to reduction of income and poor access to the healthcare and increased personal spending, and all leads to a catastrophic thing. So in this background, let me just giving little highlights on the burden of NCDs. In 2016, NCDs were responsible for around 41 million of the world's 57 million deaths, that is 71%, and 15 million of these deaths were premature, 30 to 70 years, and burden is greatest with the low and middle income countries, where 78% of the NCD deaths and 85% of the premature deaths had occurred. These are the WHO data. As per WHO NCD India Profile 2018, NCDs are estimated to account for 63% of the deaths in the country, in which the cardiovascular diseases lead with 27% of the overall mortality cause, followed by chronic respiratory diseases of 11%, cancers of 9%, diabetes 3%, and others of 13%. Now, I would like to refer to the another study which was ready, and I hope all my learned colleagues are aware of, the India State Level Disease Burden Initiative that was conducted by ICMR, where the 4 common NCDs of cardiovascular disease, cancer, diabetes, and chronic respiratory diseases account for 57% of the total premature mortality in 30 to 69 years of age group. And cardiovascular diseases were responsible for 28.1% of the dialysis, and chronic respiratory diseases contributed to 10% of the dialysis, and cancers 8.3% of the dialysis. So this sets up the stage, and we all agree to with presentations made by our previous speakers that we need a dedicated and a program that looks into the NPHCE, that is, we're looking after cancer, diabetes, then we look into the stroke along with the cardiovascular diseases. So this is the history how the program started. We had started in a very small scale of 2008 with a pilot in 10 districts. Then subsequently we had expanded to 100 districts in 21 states in 2010. Then we moved in 13 and 14 with integrated with the National Health Mission. We rolled it into all 36 states and UT. And a scheme for tertiary cancer care centers were initiated. That was the older cancer program that was made part of it. Then opportunistic screening at the public health facilities and outer-state screening was done for these common NCDs. In 15 and 16, the number of districts increased in the states from around 468 districts. 17, the national health policy, which again re-emphasized the integrated approach for the population-based screening. And 2018, there was a paradigm shift, and comprehensive primary healthcare through the Health and Wellness Center was introduced. That was Ayushman Bharat was there. And the PBS and NCD services were made essential packages as part of the Ayushman Bharat scheme. So when we talk about the program, what are the objectives of the NPHCEs? Number one is health promotion through behavioral change. We are doing a lot, and we are trying to do much more than what we are doing. Second part is population-based and opportunistic screening at all healthcare levels. Prevention and control of the chronic NCDs. Number 4 is capacity building for prevention of early diagnosis, treatment, rehabilitation, IEC, BCC, and operational research. Fifth part is support and diagnosis and cost-effective treatment at all levels. Then sixth is the development of database of NCDs to monitor mortality, morbidity, and the risk factors. So these are some of the activities which are the objectives of this particular program. Then we talk about the components, how this program is working through. We have the wings of health promotion, screening and early diagnosis, case management, capacity building, supervision, monitoring, and evaluation. So this is any pillars of any of the programs. So I will just emphasize a little more in a wider way exactly how we are doing so in implementing these activities. We have a national NCD cell which is located at this directorate, which we are sitting. We have the state or the UT NCD cells where around in all 36 UTs. We have the district NCD cells, which are around 665 in number, and the district NCD clinics are located at the district NCD cells, or sometimes at the district hospital. They are around 637 in number. Along with it, we have the CHC NCD clinics. They are around 4,472 in number, which are being fed by the PHC and subcenter wherein the patients are being referred to. Along with it, we have the cancer chemotherapy. We have the dedicated daycare centers, which are generally located in the district hospital for the cancer chemotherapy, which are around 218 in number. We are also supplementing our efforts for the cardiac care with having a cardiac care units, which are at 181 in number. So these are some of the structural architecture of the program, how the program gets implemented from the national level to the periphery. So this is some of the, I feel, hopefully the slides are also moving with me. Some of the glimpses of some of our CCUs at Kerala, district cancer facilities, the NCD cell which are being inaugurated in Orissa, and a CCU which is there in a hospital in Leh. And these are some of the cancer care centers which have been there. So this was just an glimpses of what our programs have been doing. Then if we go into the Health and Wellness Center or the Ayushman Bharat, a little bit of glimpse, I hope everybody is aware of by now. So there is an expanded package of services which looks into health promotion and wellness and reaching it to the last miles so that the continuum of care is completed under this particular umbrella. Under this, NCD also becomes very important because if we looked into the essential package of services which have been delivered under the Ayushman Bharat, though we start with care in pregnancy and childbirth, but we should not forget that number 7 also speaks about screening, prevention, control, and management of the non-communicable diseases. So that means, because this is one of the flagship program of Government of India, wherein the NCDs have been taken into account and they are very important, which the government also agrees to. So now if we go into the screening part, which we had already told you that this is one of the very important, because we should know whom to deliver the services for. So if we talk about the screening part, we had launched a population-based screening, a very, we can say, a package under the comprehensive primary healthcare in 2018, where we have targeted all persons greater than 30 years of age in the community for the common NCDs. So where we are doing the prevention, control, and screening services through trained frontline workers of ASHAs and ANM, which is linked with the referral support and continuity of care. This is one of the places we are also screening the geriatric population to know exactly what is the quantum of hypertension and diabetes which we are having in the community. And it has been implemented in around 480 districts through the Health and Wellness Center as part of the comprehensive primary health care. The population-based screening helps in better management of diseases by way of early stage of detection, follow-up, and treatment adherence, because we know whom we have to give the services for. Also generates awareness about the risk factors for the NCDs so that our younger population does not have or happen upon this cardiovascular or other diseases, which we can at least prevent at the earlier stage. Now, if we look into the software, just giving you a little glimpse exactly how we are collecting the data. Now, this is developed in collaboration with Tata Trust and Dell India with experts from All India Institute of Medical Sciences, PGI Chandigarh, this directorate, NSSRC. They had used all their technical expertise to build this software. They have the capture and individual beneficiary data at the population-based screening. This ensures the continued support for screening and management. There are basic 6 modules under this population-based screening, through which the continuum of care across the facilities and locations have been provided. There is for the ASHAs, we have the ASHA mobile app. We go one step higher. At the ANM level, we have the ANM tablets wherein the data can be fed in. When we go to the PHC, at the PHC, we have the medical officers web portal. Then we go further to the CHC and the district hospital. We have the CHC and the district hospital portal. And above all, we have some administrative portals and the health officials dashboard, so that in the administrative portal, we can manage all other portals, and through the health official dashboard, we can see into the key data, exactly the number of beneficiaries, the number of people who are getting screened, and whom are the medicines have been delivered. So this gives a glimpse, eagle's eye view, basically. There are certain new additions to the system, like comprehensive clinical decision support system for hypertension and diabetes, so that we know exactly what are the drugs and how the treatment has to be modulated. That has been available now. Then cancer care continuum models are also being integrated into the system. And we are trying to make it interoperable with other existing softwares, what we have. As I will be coming through, I will be speaking about our integration with a tuberculosis program and other programs, so that these like diabetes and tuberculosis, they go hand in hand, so that like having some kind of a data speaking in the niche portal with this kind of this portal. So those things have also been done. Then incentive system of government for the frontline workers are also getting integrated in this particular portal. This is just a glimpse exactly how we look like at the CPHC NCD portal. These are some of the screening activities which we have already completed. Around 22.2 crores have been started since 2014 from the opportunistic screening. This is just like people visiting an OPD or an IPD of an hospital, through which we are screening for hypertension and diabetes and other cancers. Then we had ITRES screening, though it has been discontinued since 2019, wherein we had screened of 10.7 crores of people. Then we go into the population-based screening, which I was explaining to you all people. We have around 4.04 crores. Then we have ABHWC screening that is done through the ABHWC. There is another portal of the Ayushman Bharat, where we have covered around 11.7 crores of people. So this is just giving a glimpse exactly how the Ayushman Bharat, what are activities that have been done. There is the ASHA and then MPW module through which the population enumeration has been done. I hope people had before me had already spoken about the population enumeration and the CBAC forms, and the outreach services are been given, and the community-based screening are been given. Along with, they also do through the CBAC form the risk assessment and awareness generation. That is helping us to know exactly what all are the beneficiaries whom we are looking into, and also helping them to teach what all are the risk factors for NCDs. Then follow-up of the confirmed cases and counseling and lifestyle changes and treatment compliance. That has been expected at the village and the urban health level, the ASHAs and MPWs, through which we are screening these people also. Then we go to one step higher, where we have the health and wellness centers where a CHO has been sitting. Then we have the first level of care where we have the screening taking place. We have the diagnostics like the glucometer and other equipments through which we can know the blood sugar, blood pressure. The drug dispensation is taking place, and the record keeping is also been done at the sub-center level. Then the telehealth services are also being done through, and the referral to medical officer at the PHC for the confirmation and complications have been done. Then we move to the PHC level, wherein we have the medical officer sitting, so he can confirm the diagnosis, because the rudimentary diagnosis have been done through the sub-center level, but the confirmation of the diagnosis happens at the PHC or the EPHC level. And then the prescription and treatment plan has been given, and the referral of the complicated case along with telehealth and real-time monitoring. Then we move to the CHC subdivision hospital and the district hospital. We have the advanced diagnostic with the complication assessment along with telehealth and tertiary package of PMS, RSSM. So these are activities what we are doing under the Ayushman Bharat scheme through which the screening has been done. Now we look into the other NCDs also, like one of them being the chronic renal diseases, which we have under the NPHCE program, the Pradhan Mantri National Dialysis Program, or PMNDP we call it in the short form, which was launched in 2016 and 17 to support all the district hospitals in a PPP mode, wherein the service provider has been asked to provide the HR, dialysis machine, RO plant, dialyzer, and consumables, and government is supporting it through the space in district hospital, drugs, power, water supply, and cost of dialysis for the poor patients. So here, this is one of the areas where the geriatric patients are also getting who are suffering from the chronic kidney diseases. So on 7th of April 2016, the guidelines were developed and released and implemented in all 35 states and UTs in 496 districts and 874 centers. So as of 31st of May 2020, deployed of around 5,415 hemodialysis machines have been deployed, with a total of around 7.37 lakh patients available dialysis services, and 74.45 lakh hemodialysis session has been held. Now we move to the other disease, that is cancer. That is something which is what we are trying to do, though it has been done in an umbrella fashion. There are a lot of contributors to this, but our contribution I am just highlighting. This has been state up with, we have the setting up of the state cancer and the tertiary cancer centers. This is just nothing, but we are trying to strengthen only those warning institutes wherein we are giving some kind of aid so that they can be made better. A maximum amount of around 120 crores have been given for the SCIs and 45 crores for the TCCCs. There have been planned establishment of 20 SCIs and 50 TCCC, which has been there in the pipeline. 39 institutions have been funded so far with a 60-40 ratio in the normal states, and for the northeastern region of 90-10 ratios. So when we talk about the SCI and TCCC, what are the activities that have been done over there? The tertiary care diagnosis and treatment, coordinate and galvanize the cancer-related activities in the respective geographical areas, training of the doctors and the health personnel, outreach and screening activities, research activities, and participate in the cancer registry program, which is run through the ICMR. Now we move to the other disease aspect. What we do it for hypertension. We have through ICMR and the state governments and WHO a project called Indian Hypertension Control Initiative, which aims to reduce the disability and death related to cardiovascular diseases by improving the control of hypertension, reducing salt consumption, eliminating the artificial trans fat. 25 districts in 5 selected states have been covered in phase 1. Covering of 100 districts have been proposed in the phase 2 states. This is to strengthen the cardiovascular disease component of the NPHCE. So these are some of the treatment protocols. There is a standardized treatment protocol that has been developed with the help of ICMR and WHO, which has been there. And these are the medications which is there, which start with telmisartan along with amlodipine and chlorthalidone.
Dr. Pradeep,
yes, sir.
Dr. Pradeep, we need to please hurry up because already we are much beyond time actually.
Yeah, sure, sir. So I'm just clipping those slides. Let me just skip through and just give you some of the glimpses. So there's another project. What we do is the ST elevation myocardial infarction, which has been implemented in some of the states, wherein we have a hub and spoke model, so that through the spokes, which are generally in the district hospital, and hub may be a medical college, we can, through reading the ECG, we can understand whether we are having an ST elevation myocardial infarction or not, so that we can give an initial thrombolytics treatment to the patients, those who are getting implemented. And these are the states and the districts which are getting implemented. So other initiatives what has been done in this program are like a TB diabetes already I had spoken about. a national framework for joint TB, diabetes, mellitus collaborative activities have been done under the program, so that there is a data sharing and sharing of the information between the TB patients with the diabetics and the diabetics with the TB, so that both the programs can avail the facilities. Then we have a pilot project of around 6 districts where the integration of Ayush with NPCDCS has been done, because we'll all appreciate that yoga is one of the important therapies when we talk about the primordial prevention of NCDs. Then we have already spoken about the IHCI. Then we have the National Urban Health Mission, under which NPCDCS program is also getting implemented. So I just wanted to add upon, there is other diseases also which has been added upon to the basket of diseases, like COPD have already there, and non-alcoholic fatty liver disease is also been included under the NPCDCS umbrella. So some of the promotive activities, that is health promotive activities, we are all aware of that our Honorable Prime Minister had already launched in 24th of September 2020, the Fit India movement, through which we are also looking into the 3 age categories, that is the 5 to 18 plus, 5 to 18 years, 18 to 65 and 65 plus age group, which we are looking into mainly towards the 4 activities which we are doing and we are promoting, that is avoiding the risk factors like no tobacco, harmful use of alcohol and drugs. Physically activity has to be there, healthy eating and work-life balances. Then for the preventive aspects, what has been done is that already here is a physical activity of walking, running, cycling and swimming that has been taking place, creative activity which we had already spoken about, and screening for early detection. Then these are some of the glimpses from the field. And this is my last slide, and I'd like to thank all my organizers for giving me this opportunity to speak. These are some of the famous quote of Gandhiji, who just said, in a gentle way, we can shake the world. And these are some of the IEC materials which we are also percolating down to the states for cancer, stroke, blood pressure and others. Thank you. Thank you all.
So Dr. Pradeep, thank you very much. I understand it's a very, not only a very big program, but there are multiple challenges. So I'll request Dr. Sanjay to add something.
I think it is very comprehensive, lot of information, and it will take time to understand what kind of challenges you are dealing with. I just a small clarification or maybe a suggestion. Just wanted to know from Dr. Pradeep, you must be collaborating with National Digital Health Mission, because all these diseases they record, telemedicine and other things. So probably you would have been taking care of that. That was the only thing. Thank you.
Yes, sir.
And one thing, Dr. Pradeep, one small provoking question. You must be aware that, in India as of now, almost 40% of the hypertensives are uncontrolled, though they are on drug. So because and also diabetics, similar situation. The program is in there for so many years. Do we have some mechanism at the community level? Like in a blindness program and deafness program, we have some definite data. This much cataract, this much operated. Like, do you have some mechanism that how much of the hypertensive diabetics are actually under control? Because study after study still says that is a majority are uncontrolled. And these two problems are basically leading to the morbidity, cardiovascular disease, cerebrovascular disease. Anything there?
So as of now, to my knowledge, I feel we don't have, because this has to be done through a research mode. This may not be done because in the population-based screening, we are going to the population through which we are capturing the data. So that has to be taken in a study mode, and that can always be taken up in future, or if it's already there, I have to just find out, sir.
Right. Thank you.
That was all from my side.
Thank you, Dr. Pradeep. So now I think floor is for Dr. Gauri to lead, because it is a challenge to discuss the challenges and the road ahead. So we have
It's yours only to moderate. It's just that we will have very good inputs from Dr. Proshun Chatterjee, who is currently heading the Department of Geriatric Medicine at AIIMS, and he also happens to be heading the Regional Geriatric Center at AIIMS New Delhi. And Dr. Atri Ganguly, who is representing the program from the WHO side. So quick views from them. And I'm there only to assist. That's all.
So friends, we basically heard all our speakers, and we find that there are a lot of activities. And one of the main purpose was how to really integrate with our geriatric program so that maximum benefit ultimately reaches the community. So I will invite Dr. Prasun Chatterjee to share his views. Dr. Prasun, please.
Unmute yourself. Unmute.
Dr. Prasun, please unmute.
I think now I'm unmuted.
Yes, yes.
Yeah.
Yes.
So thank you. Thanks for this opportunity, and thank you, sir, and thanks to Dr. Gauri for considering me in this session. I think most of the speaker were they're great in policy making. I'm little odd man in this session, I believe, but what I understand is definitely LASI first wave data is very high quality, robust, and it is representative sample. So, and it has stressed the need of comprehensive assessment of older people where multimorbidity, geriatric syndrome like fall, frailty, malnutrition, depression, cognitive impairment, functional status should be evaluated routinely during usual assessment, which need to be in our usual practice, which is still not there. And I think, as Dr. Gauri mentioned, what is way forward. So I would recommend from my clinical knowledge that it should be mandatory that we should focus on more of integrated capacity building, where every medical officer, nursing staff, paramedic staff, peripheral health workers, community health volunteers, all of them should get sensitized with this holistic care, which is beyond disease specific care, because until recently we were doing that only. And most importantly, which even LASI data has focused, that functional loss has a major impact in elderly healthcare. So I believe this, other than this capacity building, LASI data has also emphasized the need of integrated care model, where we'll not only focus on chronic disease, but also assessment of intrinsic capacity, functional capacity, socioeconomic status, environment, and it has also underscored the need of promotion of healthy aging through lifestyle modification and behavioral changes. As throughout the days we are discussing that, which should reach up to the wellness center, and I think Dr. Gauri can tell better that, and we have to plan together. So the integrated care should comprise home-based care, community awareness, long-term care, and there should be smooth referral from community care to primary care to tertiary care. I understand it is difficult, but that is the need of the hour. Again, that LASI data has stressed that fact, and I think it is possible when we engage multiple stakeholder, as many previous speakers have also mentioned. When we engage various existing program of Government of India, NGOs, civic body, to provide comprehensive care for older people. I think that's all from my side. Thank you. Thanks again.
Sir, unmute.
Dr. Prasoon, I think you have spoken our mind, because when I and Dr. Gauri was discussing, we're basically harping on this only. It has to be integrated so that the maximum benefit reaches the people. And I think you have really touched the point. Thank you. So I invite Dr. Atrey Ganguly to share your views and for guidance and future. Go ahead.
Okay. Good evening, everybody. At the outset, I must congratulate the Ministry of Health and Family Welfare for bringing out this report. Definitely, this is a very path-breaking feat, because so far we had been planning services. We did not know what the actual burden was. But now we will definitely know what the burden is and will help us in planning. As we all know that the decade of healthy aging, the UN decade of healthy aging has already started 21 to 30. And India is one of the key countries who are contributing to the global scenario. The global report, which was launched last month, we had Dr. Gauri and the Joint Secretary Vishal Chauhanji presenting. And we look forward to more inclusion of India in the global scenario. Secondly, I would also congratulate the government of India today, because the thought they have brought into conducting this workshop post the release, because one of the pillars of decade of healthy aging is that aligning the health systems to the need of the elderly, and integrated care is the mantra. So it is a very good opportunity wherein we already know that there are different programs which are contributing. It is now time to consolidate and create a framework. Not only in terms of services, I would also say that the data that is generated in each program should be collated at a level so as to see what services are actually being given to the older people and how the existing services can be modified to reach to them to the maximum. Thirdly, yes, healthy aging is not just health. It has got the non-health sector, and we need to work because the consequences of non-health sector in terms of security, in terms of financial, prospects for the older people has a lot of bearing on the health of the older people. Out-of-pocket expenditure is quite high in our country. So, with the integrated care for the older people under the banner of the Health and Wellness Center Geriatric Package, and also the NPHCE will go a long way in preventing this to reach the universal health coverage. Also, the WHO also proposes something called the ICOPE, which is the integrated care of older people, which is exactly what is being discussed the whole of this afternoon. So I'm very happy and I congratulate once again for this initiative. Thank you so much. Thank you.
Thank you, Dr. Atri, for your encouraging words. And Dr. Gauri, you like to add something?
Yes, sir. I would just like to add that as far as what Dr. Proshun has said and Dr. Atri Ganguly has also said, 2-3 things which the National Program for Healthcare of Elderly is definitely garnering to achieve in the near future. Definitely, Decade of Healthy Aging is going to have India addressing all the pillars in various formats. But yes, we will be delivering, or at least trying to deliver, comprehensive geriatric assessments and care systems, whether within the existing system or through collaborations with various partners. We will be developing a lot of models and trying it out, and definitely our mantra is going to be comprehensive geriatric care, no more just individualistic kind of a thing. So that, I assure, will be my endeavor in the coming few months. And second component is that LASI data, like I had said at the start of this particular workshop, is that we have just started to pick the first layers of the LASI data. That's it. So first, this is just the overview workshop. And after this, we are planning integrative, detailed discussions for aligning every single program towards elder care needs. And at the end of it, not only these 6 programs, we already have been approached by the other programs also. So that is the second thing. And not only the Government of India programs, we do acknowledge the fact that yes, health is, like I had said in the morning, that our ultimate aim is to develop a society for all ages. So anything and everything that comes into that picture, wherever health can take a lead, we shall endeavor to do that. Saying said so, I think this is something which requires the collaboration of a lot of partners. I mean, we cannot minimize the value that can be brought in by the other partners or stakeholders into this. Health, yes, can take care of it. But LASI has shown another thing, that the social and economic dimensions need to be taken simultaneously, not one after the other. So that is something which we will need to develop, because interministerial, interdepartmental and other things is very good on paper, but actual implementation and actual delivery of services and actually monitoring it and sustaining it is it's a humongous challenge. So that is something which we need to develop. We need to evolve mechanisms to deliver as well as monitor. So that is something which we need to work together at a later stage, maybe. So saying said so, I'm really glad, and I would really like to thank all my seniors, my experts, and everybody. And I can see Ritu has joined us from WHO International. I'm so thankful to you. And we had Bas Bierman from USC and everybody. So I'm really humbled, because when I was given this task, 3 days for the release of this document and conducting this workshop. Believe me, it was impossible. And I am really humbled by all these people who have sat together for more than 5 hours. And I know all of us are partners in this process. And I'm really, really very thankful to all of you for accepting this short time and accepting to be a part of this thing. So thank you very much. And I assure you that in the coming months, we should be able to come out with very good reports, models, and replicable and sustainable models, which we will definitely try to pilot and maybe even make state-specific mechanisms. So that's it, sir. Thank you so much for giving me the chance to say a few words. Thank you. Unmute, sir. Unmute.
And then I can only summarize that we had a very fruitful workshop. And as you said, extra mile, and Dr. Prasoon also said integrated. I think we have to really walk extra mile, because all the programs have their component. We have to really take them inside, because we have to go the extra mile, so that actually we achieve an integrated care. Otherwise, many of the things will be available, but at least it will not be reaching at the ground level. Yes. So I think definitely we have to work more on this issue. But I think it was an eye-opener, and we see that a lot of activities are being done in the various geriatric fields, and we need to dovetail them and for the ultimate public good. So I think with these words, we can end this today's beautiful workshop, and we hope that we'll meet very soon.
Thank you.
Thank you again. Thanks, everybody.
Thank you. Thank you.
Thank you. Thank you. Thank you.
Thank you very much. Bye-bye. Thank you.
Thank you.